time, and how much time you dedicate it for assessment, for example. So let's say, for example, Kahoot, we actually, we take about maybe 10 minutes of the learning phase 3 time. All right. So, so what happened is that, of course, each question has maybe a one minute time limit. All right. Or it can even be shorter. It can be 30 seconds for them to respond, depending on the level of difficulty of that question. Okay, so we look at the time arrangement, and we look at the sequence of what do you call that, activities that you want to also look at. All right, so if let's say, for example, we're looking at VR simulation, all right, we can, because the limitations on our end when we talk about virtual the virtual laboratory, as shown to you, is the device itself. Okay, so there's always this talk about scalability. How I only have one set and everybody needs to have a hand in it. So how much time are we given, or each student is given to have the experience? So in the VR experience, some students are a bit more savvy, the students are a bit more savvy when they use these devices. So they take a very short time to adjust and to acclimatize to the the virtual environment. But some students really struggle. But because typically in a class we have a class of 25 students, and we subdivide the students into teams of 5. So because of the limitation of the devices, we have to limit the contact time of those devices to maybe about 15 minutes per group or per team. All right, and when we talk about the learning phase 2, then how long does it spend? So we have like 15 minutes per team, so it will probably take about 1.5 hours easily. Yeah. So it's really about timing. When I shared with you about the learning phase 1, 2, and 3, for learning phase 1, there was about 1 hour. Okay. Learning phase 2 is about 1.5 hours. Okay, and learning phase 3 is about 2 hours. Yeah, because in learning phase 3, when we consolidate the information, the students are required to do some form of presentation. Yeah, I mentioned to you as just now as well, and the presentation can be in a form of PPT slides. It can be in a form of a quiz. It can be in form of role play. It can come in different forms, and depending on the creativity of the students, we don't limit that. Yeah, so when you talk about timing, that's how we divide our timing into the 3 learning phases. But of course, we have to be mindful what the engagement time with these tools that we are implementing. Interest, students' interest. Okay, I always encourage career guidance. All right, whereby we have learning journeys for our students. I mean, of course, in this COVID situation, it's very difficult for us to actually, bring our students out for learning journeys. Typically, what happens is that we usually bring our students out to the laboratories, okay, to introduce them to the profession. All right, and get them to actually, view what is it like, the environment is like. But because of this limitation, again, during this period, we invite speakers to speak to our students. So there's some form of engagement. So we invite speakers from the lab, which is either from the medical laboratory, the diagnostic labs, or we can invite speakers from the research labs. Apart from that, our biomedical science students do not only just embark in allied health professions, like for example the diagnostic laboratories. There are also other allied professions that they embark into. So some of them do go out to further their studies in physiotherapy, in diagnostic radiography. So we engage all these professionals to speak to our students, because it somehow or another creates that career guidance for them. Yeah. So when they see, it's relevant. How is it relevant to my diploma in order to get to where they are from, where they are going? Then it invokes their interest. Yeah, and we have the various departments, right? So from hematology to diagnostic pathology to clean chemistry. Our students are usually very fearful of the word chemistry. So, but when they understand a bit better what it does and what exactly it means, then they're not so fearful. Yeah. So we also have mentors as well, all right, to engage the students in career guidance. Yeah. So
okay. Thank you very much. I think that's very, very thorough and clear. So there's another question, and I think time-wise, it will be our last question. It's from Dr. Yuka Adriana. Mrs. Aliza, how is it related to the standards of assessment and evaluations? And what are your suggestions?
Okay. Okay, so if let's say, for example, we look at assessment, all right? One of the things that we have when we look at assessment, we have to ensure that the assessment is authentic. All right. And we look at whether
excuse me, what do you mean by authentic?
Whether it with authentic means, like, for example, are we testing what the students learn?
Okay.
And is relevant to applicable to their the real world experience. For example, when we look at phlebotomy, all right. So it has to be we have to give them the scenario of, okay, what are you expecting as a phlebotomist? And the thing is that we have to assess them when they are in that role. We also have to consider in terms of whether it's fair. Okay, how the test is being conducted. Is there any form of biasness?
His Excellency, the first Vice Rector.
Reliability, so that it's consistent and reproducible.
National Conference on
the test has to be
KEYNOTE,
administered to the students.
Mrs. Ani Wahyuni Rahmawati, founder and publication director of Research Synergy Foundation Indonesia, Dr. Hendrati Dwi Mulyaningsih, head of KEYNOTE International Publication Division, and all audience. Good morning. First of all, praise be to Allah Subhanahu wa Ta'ala, who has given us His blessing and mercies, so we can gather here today in healthy and condition.
Or does it measure?
It is really an honor for me to welcome you all. Welcome to Bandung International Conference of Medical and Health Sciences 2021 UNISBA implemented virtually.
Right. So
this is a series of activities for the 17th anniversary for Medical Faculty UNISBA.
Thank you very much, Mrs. Aliza.
I'm here on behalf of the
to
rector.
Summarize our discussion today.
We still have best regard and apologies cannot being able to open the
implementation of
today. He
tools
was
in the curriculum is very important.
Keynote speaker.
Although they have also benefits and challenges, we still have
graduation
to try
ceremony
because
at Islamic religion
the
higher
ability
education
of
in Garut,
students
Indonesia.
is varied, and the ability of lecturers also varied.
I
So
would
we
like
must
to
have
say
some
thank you very much for the
standardized
entire committee of
tools
the
that can
international
develop
conference
the skills and knowledge of
who had
students.
hard work
And
to
also,
prepare this
we
conference with good,
still have
and
a very
especially to
important
all
factors
some are free,
in
some require
edtech
some
is
investment.
that creativity of this
Now,
of
what is the
the
purpose of
human
incorporating
is
these
still very
edtech
important.
tools? What is the
So
desired
tools is
outcome
just
that
tools,
you,
but
as we as
without
educators,
human touch, is
would
still
want to achieve?
it
How does
can
it
only
fit
be
into
tools
our
without
curriculum
any
delivery? We also want to
benefit.
also assess what is the level
So
of
maybe that's all
interactivity that we are
from this
expecting from the
discussion.
students.
Thank you very much,
Okay.
Miss Aliza. I
What are
hope
the
we
resources
keep
and
continue our
capabilities needed?
collaboration,
Do we
and
have
maybe in
access to these resources?
in much bigger level next time. So thank you very much for being with us.
These tools can be
And
used to
thank you for the audience who's very, very responsive, very interactive. And I think all of us agree that our objective now is how to help students to learn better. So thank you very much. Assalamualaikum warahmatullahi wabarakatuh. I return this to Miss Santi Rahmawati. Thank you.
Okay, thank you. Yeah, thank you. Yeah. Okay, please, Pak Yusuf.
Colored aggregate.
Well, thank you very much. Okay.
Now, whenever you grind and polish
thank you so much,
other
Dr.
overlays,
Titik
it's kind of like a
Respati
really
as the
creamy
moderator,
finish. It doesn't really
and
look like concrete. So in theory, at least on this one, once you grind the cream off the top, it's going to expose that aggregate that is in this mix. That is not any typical self-leveling overlay.
There are sound.
Some sound.
Okay. Hold on, let me check. Where the sound? Okay.
where the sound comes.
Okay.
Well. Okay, once again, ladies and gentlemen, please give a warm of applause to our speaker and our moderator today. And thank you so much, Dr. Titik Respati as the moderator, and Miss Aliza Ramli from Republic Polytechnic of Singapore as the plenary speaker. We learned a lot from the topic and the discussion, and thank you very much.
Okay, thank you very much once again. And for Dr. Titik Respati as the moderator in the plenary, in the first plenary speaker, I just get a message from the committee that you have to choose one of the interesting questions that already asked by the participants, because one of the questions will be given a special token from the committee of the BICMHS.
Will do.
From the questions, you.
I think the first one is from the first one.
Okay, the first one from Dr. Yuniati,
we
right?
only have 3 questions, yeah?
Yes, yes.
Okay, so then the first one.
Okay, the first one, noted. So for Dr. Yuniati, congratulations that you are being chosen based on the moderator as the interesting questions to be asked to the plenary speaker. And then later on, from the committee, Dr. Eka will contact you. Okay, thank you so much. And then moving on to the next agenda, as the recognition and appreciation from the BICMHS committee, we would like to give a token of appreciations to our plenary speakers and also the moderator. So please welcome Dr. Arif Budi Yulianti, DRA MSI, to give a token of appreciation to Miss Aliza Ramli from Republic Polytechnic Singapore as the plenary speaker of BICMHS 2021. Please welcome.
Okay, thank you, Mrs. Aliza. Thank you for your appreciation at this conference. Thank you for your interesting and inspiring, lovely presentation. Hopefully, in the future, we can do collaboration research. All the audience, please give her big applause.
Thank you very much, Dr.
Thank you so much, Miss Aliza Ramli, hope to see you again in the future collaboration.
Inshallah.
Thank you. Inshallah.
Assalamualaikum.
Okay. Waalaikumsalam warahmatullahi
wabarakatuh.
wabarakatuh. Next, please welcome again. Stay still, Dr. Arif Budi Yulianti, to give a token of appreciation to our moderator, Dr. Titi Krespati, as the moderator of the first plenary speaker of the BICMHS 2021.
Thank you for your doing well as moderator and the plenary session in BICMHS 2021.
Nuhun, Bu Abe.
Audience, please give her applause. Thank you, Mbak Titi.
Thank you, Hasan
Nuhun, Bu Abe.
Okay. Okay, back to Mr. Yusuf.
Okay, well, ladies and gentlemen, moving on to the online presentation session. Today we will have two sessions of the presentation session. And now we will have the first session that will consist of 3 presenters from Health Science and Infectious Disease track. In the session, we will have Professor Dr. Nur Halim Sahib, Doctor, as the session chair. And before Professor Nur Halim chairing the session, I would like to read his profile. Professor Dr. M. Nur Halim Sahib, Doctor, is a biochemistry and molecular biology professor at the Universitas Islam Bandung, Faculty of Medicine. Molecular genomics and molecular botanicals are his areas of expertise. To further his knowledge, he has traveled around the world, and also he received his undergraduate to postgraduate education at the Universitas Pajajaran's Faculty of Medicine and his postdoctoral studies at College University in London and Kyushu University in Japan. He has also completed internship research at Monash University and St. Vincent's Hospital in Melbourne, Australia. He has received numerous honors, the most recent of which was the Outstanding Intellectual Achievement Award in 2014. Okay, Professor Nur Halim, please welcome.
Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you for the nice introduction. Good morning, everyone. It is, ladies and gentlemen, it is a great honor for me to be a moderator in this event. It would be 3 speakers. They are Ike Rahmawati, then Dr. Yutiana Harisma, and then the third is Anissa Rahma Fukani. So if Dr. Ike Rahmawati has been ready, please, I will invite you to speak in this session.
I'm already in Zoom, Prof.
Ya, Waalaikumsalam warahmatullahi wabarakatuh.
Assalamualaikum. Oh. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. All committee, the honor of the chair of this session, Prof. Nur Halim Sahib, all college. Allow me to present my short presentation about my study. Is it I can share my own presentation or?
Yes.
Okay. Okay, I repeat again. Allow me to give short presentation about my study with the title physical and blood examining characteristic of shift worker nurses in pandemic COVID-19. My name is Ike Rahmawati Ali. I'm from Medical Faculty of FKUnisba from Physiology Department. If we see this picture, this is the picture of health worker who died because of COVID-19. Maybe one of them was our friend. Deep condolences and pray for them all. If we see this picture, say that 70,000 health workers had died from COVID-19 in the past years. And I found in July 20,000 data shown in Indonesia, 14 and 59 health workers in Indonesia died because COVID-19. And among them, 50 and 45 are doctors, 45 and 33 nurses, and the rest as other. Indonesia was the highest health worker died and 5th rank in the world. This is very sad. In COVID-19 pandemic, health workers such as nurses who work in hospital has a high risk for getting infected with this virus because they interact directly with the patient COVID-19 in hospital. For many studies state that this COVID-19 infection is more common in the elderly, in the men and subject with diabetes mellitus, hypertension, cardiovascular disease, and malignancy. Nurses mostly have to do shift work in their job at hospital. And shift work is rotating with time outside normal working hour, either by rotation division of labor method or permanent for a period for 24 hours. What happened in shift worker? In shift worker, there is discrepancy between the timing of endogenous circadian rhythm and behavior cycle, including sleep cycle, wake cycle, and feeding cycle. It is related with suprachiasmatic nucleus as the center of the circadian rhythm. The center regulates leptin level, plasma glucose, glucose tolerance, corticosteroid, cardiovascular function via neural or humoral signal to associated tissue. In shift worker, there is sleep disorder associated with shift work. This is because there is aberration in circadian rhythm, which is established the main cause of metabolic and cardiovascular disease. And in shift worker also, there is increased body weight and abdominal fat, especially when they do shift rotation in the night. And many nurses and with midwife are also affected. As we know, increased body weight and abdominal fat are the risk for many metabolic diseases. Changing in circadian rhythm caused by this shift work make changes in metabolic and hormonal, and this is result increasing in blood pressure, blood sugar. So later it is affect to function of blood vessel, and the end it result in person work capacity. Study had shown that when subject ate and slept for about 11 hours outside in their usual phase, they exhibit decreased leptin, increased glucose, increased insulin, reverse daily cortisol rhythm, increased mean arterial pressure, and reduced sleep efficiency. This is make detrimental cardiometabolic implication of circadian rhythm disturbances. So I make a study. The study of aim is to determine the risk factor for nurses who work shift with the exposure to COVID-19. First, due to the shift work, there can be changes in their metabolism. Thus, this has become a risk for COVID-19 infection. The study shown there are many factors in shift worker nurses, such as body mass index. There are high blood pressure and high fasting blood glucose. The method of this study is cross-sectional study with purposive sampling. We took nurses who work in hospital, including criteria were female nurses, aged about 20 and 40 years, who work in Al-Ihsan and Muhammadiyah Hospital in West Java. Length of work is hospital is more than 9 months and had no previous cardiovascular disease and diabetes. The nurse were taken identities such as age, working unit length, working in hospital, physical examination such as body weight for taking body mass index, taking blood pressure, and rest pools for estimate the VO2 max, taking blood exams such as cholesterol, fasting blood glucose, triglyceride, cyclic guanosine monophosphate, and ESR. This ethical clearance for the research was approved by Research Ethics Committee of University of Indonesia. Subject was asked informed consent and approval for measuring physical and lab examination. The result from this study, we can see, there is 20% or about 50% had age more than 30 years old, and about 31 people, or about 77.5, have working period more than 5 years. Most of them work in ward, about 80%. Most of them has a normal blood pressure. Only 1% in systolic blood pressure not normal, and also 1% in diastolic blood pressure not normal. And in BMI, we can see from the data, there is 23% have the BMI more than normal. There are about 50 and 7.5, and only 3% has had not normal blood fasting glucose. All of them has normal cholesterol. Only 2% has had not normal in triglyceride, and 9% had not normal in ESR. If we get the average from the data, from blood pressure, all mean value for systolic, diastolic, mean arterial blood pressure, and fasting blood glucose were still within normal limit, but we can see in cyclic guanosine monophosphate and aerobic capacity is in low level. And discussion from this study, we can see in the ICU and ER, the average nurse age was over 30 years. It is also found that the average length of work is more than 5 years. From Ansori research on the nurse state that characteristic of age about 34 years and working period or more than 10 years had tendency to the most work stress. From the data, it was found that nurses who had a systolic blood pressure above normal had BMI above 25, as well as those who had a BMI above 25 had a mean arterial blood pressure above 80 millimeter hygrometer. As many as there is a 90 per people. From dua study, there is a relationship between BMI with blood pressure, and lady also state that BMI had a strong relationship with hypertension. And Tatsuya also state that average blood pressure level will be increased with increasing BMI. From BMI calculation, it found that 23 nurses, or about 57.5% of the sample, has BMI above 25. And Lorenzo stated that prevalence of obesity was higher in shift worker than non-shift worker. It also stated from CDC that obesity was increasing the risk for severe COVID-19 associated illnesses. So in this study, found that many nurses who work in shift, or about 57.5, has more BMI more than normal. So it can conclude that indirectly increasing risk of COVID-19 infection. And also this is from high BMI also might be related with low cyclic guanosine monophosphate and VO2 max. For conclusion, the study found there were risk factor for COVID-19 in shift worker, especially in high body mass index. This is indicate that shift work may be indirectly increasing the risk for COVID-19. And from the study also suggests for nurses to maintain the healthy lifestyle. This is some reference that I use in this study. Thank you very much for the attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Ika Ramawati, for the interesting
Thank you.
paper. So maybe we continue first to the second speaker, after the third speaker, then followed by discussion. If anybody has any question, please just note that. The later we open the discussion. Okay. The second speaker is Dr. Yuktiana Krisma and Afiati and Professor Betty Hernomo and Herr Zulianti. The topic is about uterine diffuse large B-cell lymphoma non-germinal center type with multiple organ involvement a case report. So if you're ready, please, you can start the presentation with uterine diffuse large cell lymphoma. Please, your time.
Okay, thank you, Professor Nur Halim Sahib. Let me to share screen of my own PowerPoint slide, please. Okay. Can all the participants see my share screen?
Yes.
Yeah, thank you.
Please in a slideshow mode.
Oh, okay.
Slideshow.
Sorry, I can click my slideshow icon.
The button just down.
Okay.
Yeah, under. There is like the projector screen icon at the bottom of your PowerPoint panel. Beside the percentage, yeah. Yes, correct. Thank you.
Let me to present my case report in this session. Thank you to all the committee, the moderator, Prof. Nur Halim Sahib, and Dr. and all the participants that come in this session. My name is Yuktiana Karisma. I'm from Department Anatomical Pathology of UNISBA, and now I'm studying in pathological anatomy of Hasan Sadikin General Hospital, Bandung. Please let me to present our case report with the title of uterine diffuse large B-cell lymphoma, non-germinal center type with multiple organ involvement. Okay, this is the outline and the introduction. Non-Hodgkin lymphoma, or NHL, is a subcategory of lymphoma that occurs more often than Hodgkin lymphoma. According to the primary location, they are further subdivided into nodal and extranodal. NHL may affect extranodal portion that include female genital tract, which are rare and account for only 0.2 until 1.1% of all extranodal lymphomas in the female population. The most common histological subtype of female genital lymphomas is diffuse large B-cell lymphoma, which is difficult to diagnose. This is a rare case without typical clinical symptom, which causes delay in early detection. For the case presentation, a 42 years old female in September 2020 complaining the continuous vaginal bleeding for 2 weeks, and she went to the primary health care, and the doctor said that she get a uterine leiomyoma, and then she given by medication to reduce the bleeding. 5 months later, on February 2021, she get a recurrent vaginal bleeding, and in the private hospital, she underwent the cervical biopsy, and the doctor has making the DLBCL non-GC type as her diagnosis. This is the pathological finding of cervic biopsy of a private hospital of the patient. In the figure A, we can see the tumor mass that consists a lot of stereosky appearance that maybe for this reason, the patient at the first time diagnosed by the Burkitt lymphoma, but is not encouraged with the other data. But in the picture B, we can see higher magnification of the pathological finding of this patient with the HNA stain of 14x times the higher magnification. We can see the pleomorphic atypical cell with round and oval shape, and we can see the atypical mitosis, obviously, and the cytoplasmic of the cell is very scanty. So from this pathological finding, which HNA routine staining, we can see that this is the lymphoma origin diagnosis. And for the immunohistochemistry profile of cervic biopsy, this is the minimal panel of lymphoma that we can do for this patient. CD10 is immunonegative, that show in this left picture, and then the CD20 is positive. It can the doctor give the diagnosis as lymphoid origin because the CD20 is immunopositive, and the Ki67 was positive of more than 50% of cell tumor. The Ki67 is show us about the progression of the patient of the disease. And from the history taking, physical examination, histopathological examination, and immunohistochemistry examination, we conclude the patient as a diffuse large B-cell lymphoma non-germinal center type. And then on March 20 and 21, the patient went to Hasan Bandung General Hospital to undergo radiotherapy and chemotherapy. This is the physical examination of the patient on March 20 and 21. The vital sign is within normal limit, but in her eye, we can see the anemia conjunctiva bilateral of ocular bilateral, and the thorax, we can see the left chest movement on right side, vesicular decrease in right lung, and rhonchi on her right chest. The abdominal and the extremity within normal limit. And the laboratory result, we can see the patient got anemia, and this is the ultrasound examination, abdominal ultrasound examination on March 20 and 21. We can see a lobulated inhomogeneous solid of mass with the size of 6 square 5 times 4 centimeter with tortuous color flow intermesh in the isthmus and cervix, suggesting a cervical malignancy. In her first ultrasound examination, there is no enlargement of inguinal, hypogastric, parametrial, and so on. Lymph node was seen. And for radiological examination, this is her first thorax radiological examination on April 20 and 21. The chest X-ray showed no intrapulmonary metastasis, cardiomegaly without pulmonary occlusion. And from the MRI examination, we can found a multiple 11 times 8 times 7 centimeters lobulated iso-intense lesion conglomerate in the area of the fundus to the posterior cervix that comprise the surrounding organs, supporting for diffuse large B-cell lymphoma, multiple lymphadenopathy in the external inguinal iliac and right internal iliac region. And then in June 20 and 21, the patient come again to the Hasan Sadikin General Hospital, Bandung, with the shortness of breath. And from the physical examination, the patient look like a moderately ill with left chest decreases in the right chest, and in X-ray bilateral pleural effusion was found. So this patient on July 20 and 21 was underwent the right pleurocentesis of 900 milliliters of pleural effusion, and from the right pleurocentesis we can found a malignant cell tumor in this patient. This is the CT scan examination on June 20 and 21. After the patient complaining about her short breath, a lobulated solid mass in the cervix region superiorly infiltrating the anterior, posterior, and fundus, adhering to the posterior wall of the urinary bladder, infiltrate the perirectal fat and adhere to the anterior wall of the rectum. Intrahepatic metastasis was positive, and enlargement of the lymph node in the para-aortic, para-iliac, right internal iliac, left inguinal. Pleural effusion was positive with bilateral compressive atelectasis, metastasis bone disease of the lumbal 2 until 5 vertebral bodies, the gallbladder, and so on within normal limit. For the second chest radiological examination on June 20 and 21, an impression of bilateral pleural effusion were seen, especially right with bilateral paratracheal to peripheral lymphadenopathy. We can see the difference between the first and second chest radiological examination on April. It seemed like everything is good, but in the June 20 and 21, we can see the accumulation of the solution, or we can call it the effusion, bilateral effusion of this patient. So this is the histopathological appearance of pleural effusion smear from this patient. Picture A, we can see the so many cells that round in shape and blue in color. So sometimes we can just think that is it just a inflammatory reaction or something, but in the picture B, we can see that the picture of the shape and the size and the color of the cell is not normal, is bigger than the normal cell. We can see the normal cell in here. I'm sorry, it's not a very good picture, but I think it can show us about the difference of size of this cell of the patient. This is a bigger, is 2 or 5 times if we can see the difference between the lymphocyte normal and the cell tumor. And for the cytoplasm, we can see it's very scanty cytoplasm. So with the round shape, so it's typical for metastasized lymphoma into the pleural effusion. This is the immunohistochemistry staining, just to make a very good diagnosis that we are not wrong to make diagnosis as a metastasis of lymphoma on her pleural effusion. This is the CD20, is a typical staining for lymphoma, lymphoid cell, I mean, that abnormal lymphoid cell. And in this pleural effusion smear, we can see obviously the staining of the CD20 was positive. So from the history taking, physical examination, ancillary study, histopathological examination, and immunohistochemistry examination, we conclude the patient with diffuse large B-cell lymphoma non-germinal center type with multi-organ involvement. The discussion in this case, the patient suffered from more than 5 months vaginal bleeding as a chief complaint. She underwent cervical biopsy after examined by the gynecologist that presumed cervical malignancy. The diagnosis of the LBCL has been concluded after histopathology and immunohistochemistry evaluation. And HNA staining show a picture of large and diffusely scattered tumor cell with pleomorphic, hyperchromatic, and mitotic cell nuclei, that typical characteristic for lymphoma, which exclude other type of malignancy originating from other origin like epithelial or mesenchymal cell differentiation. There are many stereosky appearance dominate the field of view, like a typical in Burkitt lymphoma. Nevertheless, this disease is most often found in 5 until 10 years of age. In this preparation, there is no typical follicular growth pattern typical for follicular lymphoma. The immunohistochemistry results were CD20 immunopositive, which indicate that the tumor cell were B lymphoma cell group of origin. A high Ki67 more than 50% indicates a high degree of aggressiveness in this disease. CD10 staining is not reactive. It's conclude with a non-germinal center associated with poorer prognosis than diffuse large B-cell lymphoma germinal center type. On examination by ultrasonography of the abdomen at the beginning of the period of illness, it was found that there was a mass in the isthmus and cervix, which was quite large in this patient, while the lymph node in the abdomen were within normal limit. From this examination, we cannot determine the primary location of this uterine tumor, whether it originates from the isthmus or cervix. According to Mendet et al., the diagnosis of primary lymphoma of the cervix can be made when there is no nodal involvement and no other site of extranodal involvement is established at the time of presentation type. Gynecological involvement is seen in only 4% of female patients presenting the LBCL, but when the female organs are involved, it is associated with lower overall survival rate. The involvement of extranodal site means the worst prognosis. The prognosis usually is analyzed based on an Herbal staging system, size and extension of the disease, age, number of nodes affected, LDH level, and lymphomas grading. So for the conclusion, although rare, primary DLBCL should never be ruled out. Given its non-specific clinical symptom, a multidisciplinary approach is required to perform a timely diagnosis and administer appropriate therapy for the patient. So we are present a rare case report of uterine DLBCL non-germinal center type with multi-organ involvement. Thank you very much.
Thank you, Dr. Nitiana, for the nice presentation. And you give us complete information about the tumor of lymphoma in the uterine and cervix. Thank you. Then, as I said before, that just we continue to the third speaker, and after that we will continue by discussion. And this turn is Dr. Arnisa Rahmawati Fokane, that will be talking about literature review, transplacental transmission of COVID-19 and its teratological aspect. She is from Department of, there is no here, Medical Practice Pejajaran. Okay, please, Dr. Arnisa Rahmawati Fokane.
Okay, thank you, Professor Halim. Is it the sound correctly heard from the participants? I'm sorry. Okay, and then could I share screen my own PowerPoint slide. Yeah, I think my PowerPoint slide already seen by all participants, right?
Yes.
Thank you. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you to the committee. Thank you to Professor Nanan as the moderator. In this session, I will try to present our paper titled about transplacental transmissions of COVID-19 and its pathological aspects. As we know, that COVID-19 affects all population, including pregnant women. And these infections in pregnant women in fetal development is still remain unclear. These infections in pregnancy should become a major concern because of its potential risk of transplacental transmissions that may affect and interfere with the fetal development. So that the objective of this study is to review the transplacental transmissions of COVID-19 and its possibly pathological consequences of the event. So that we did a literature review by obtaining articles on the databases using keywords COVID-19 and transplacental or vertical transmissions, and also fetal development and congenital anomalies, and also teratology. As we know that the entry mechanism of SARS-CoV-2 is mediated by ACE2 receptors and also TMPRSS2 protein. The virus needs to interact with ACE2 receptors in order to enter the cells. And in the same time, it is also needs the protein, the TMPRSS2 protein, in order to package the S or spike glycoprotein in order to please the viral doing the fusion into the host cell. So we can say that the ACE2 receptors and also the TMPRSS2 protein are required to facilitate the entry process and also the spread of SARS-CoV-2 virus in the host body. As we can see here also in the pictures that placenta cells express the ACE2 receptors and also express the TMPRSS2 protein. And we can see here that the SARS-CoV-2 can cause placental dysfunction by inducing the systemic inflammations, oxygenations, abnormalities, and also by directly infecting the placenta, causing cell damage. And as we know that since ACE2 expression is higher in mid and early pregnancy, that we can say that the viral entry and also the trophoblast cell damage is more extensive during this period compared to the late pregnancy. Many studies have been reported that the coronavirus infections, including the SARS-CoV-2 virus, can cause some clinical problem to the mother, such as the respiratory failure and the mechanical ventilation, ICU admissions, renal failure, and also the worst is the maternal death. And we agree that most of the paper we review agree that ACE2 and TMPRSS2 protein are poorly expressed by the human placenta, especially in the late pregnancy. But we noted that ACE2 and TMPRSS2 protein are expressed in the trophoblast and blastocyst and also in the hypoblast in the first trimester of pregnancy. So fetal infections can use this pathway in the early gestation period. But then it generates more questions. Are there any alternative routes that SARS-CoV-2 possibly prefer to enter the placental tissue during the late pregnancy? We found that the SARS-CoV-2 might be using the PP4 or a CD147 to enter the cells, both of which are highly expressed in placenta during pregnancy. And the other study also showed that the virus might be used or utilize cathepsin B and L, trypsin, furin, so they can affect the glycoprotein conformation that it allows the virus to access the spike binding protein site. Therefore, it is still very possible to the fetal infections of SARS-CoV-2 occurs and interfere with the fetal development during the late pregnancy. We can see here that the infections during the pregnancy may also increase the risk factor of adverse pregnancy outcomes, such as miscarriage, stillbirth, preterm labor, fetal growth restrictions, early onset preeclampsia, and also the FIRS. Those conditions have been associated with the non-communicable disease in the neonates, such as the neurological and behavioral disorders. But we have to note also that the maternal immune response to the viral infections are strongly assumed responsible for these consequences rather than the virus itself. So we have notes that the immune response of the mother. Some study also agreed that the changes in the maternal immune response during pregnancy and COVID-19 infections may affect the fetal neurodevelopment and also contribute to the neurological manifestation in the males. But on the other hand, Zhang and Dong also reported that they observed that all neonates they observed do not manifest any symptoms related to COVID-19, even though the fetal infections is positively detected. The other study also showed that the severity level of COVID-affected mother also increased the risk factor of placental and fetal infections during the pregnancy. There are three key points that we should underline if we talk about the consequences, the pathological consequences of the viral infections. The first is detected virus on the placental tissue does not always conflicting as a marker of placental infections. And then the placental infections does not always have to followed by vertical transmissions. And the last is if fetal infection detected, it's not always followed by the fetal damage or causing the congenital anomalies. So we picture here that the transplacental transmission of SARS-CoV detected, but not always followed by fetal infections. And in the very rare cases, the fetal infections has been observed, but has not been associated with pathological consequences or caused congenital abnormalities. We can conclude that the vertical transmission or transplacental transmission of COVID-19 has been reported, but the mechanism of the transmission is not clearly established. And the event is not always followed by fetal infection, so that we can still, teratological aspect COVID-19 have not been identified yet until now. And the most important thing should we note is more significant data and long-term observation are needed to evaluate the effects of congenital infections of SARS-CoV-2 in the fetus. Okay, I think that's all I have to deliver in this session today. Thank you very much for your kind attention. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Warahmatullahi wabarakatuh. Thank you, Dr. Aliza Ramli. So after finish the speakers talking about their own topic, we still have 20 minutes for discussion. Please, anybody who want to ask about the paper, about the subject here, please raise your hand or directly to the speaker. Okay, I start by myself to Dr. Ika Rahmawati.
Yes, Prof.
Yes. How long did you the nurse that work before getting the clinical symptom? How long they work? I mean, how long they work before getting a clinical symptoms?
Okay, Prof. Thank you for the question. I try to give the answer. The symptom from the shift worker nurses maybe not acutely happen, Prof, but it is chronically because need more times. In one study, said maybe it's more than 5 years. It might be more than 5 years can be affected. The shift worker can be affected in metabolism. And
for the hypertension, maybe it's quicker than.
For hypertension, maybe it's quicker, but for our metabolic syndrome, the study say that more than 5 years.
Okay. Yes. Yeah. Okay. Thank you. Thank you, Dr. Rika.
Thank you, Prof.
Yeah. for the second speaker, Dr. Yuktiana.
Yes, Prof.
You hear me? Yeah. Is talking about lymphoma, yeah.
Yes, Prof.
Yes, I know this is very difficult to be detected in the earlier state.
Yes.
So, do you have some information from whether from other researcher or from the journal that showing that there is any molecular marker to detect it in earlier state?
Okay, thank you, Prof. Nur Halim. I try to answer the question. Yes, you are right. This is a very difficult to diagnose the patient with DLBCL with non-germinal center type, and the location is I think it's a typical location. And for the early detection for the patient in the General Hospital of Hasan Sadikin, maybe it's not routinely used, but for the literature review or journal or research or something, they said that the gene examination maybe can help, but I think it's too expensive to all the patient actually or exclusively in Bandung or West Java because the high cost. And they said from the journal that mutation from the MCD is MYC or something, and the CD79B mutation. Maybe we can predict the LBCL for the patient, but for the non-invasive identification, maybe the CT scan or MRI is suitable for the patient that complaining with vaginal bleeding. From this CT scan or MRI, we can see the origin of the tumor. As we know that the lymphoma is not come from the epithelial, so the location is under the epithelial. With the pap smear, we cannot identify it at all because the epithelial is very smooth and very intact and normal. So the pap smear cannot detect this. From the CT scan or MRI, sometime from the literature said that the nodule or the mass is hypointense, and then the vascularization for lymphoma is much more like hypovascularization. It's different with the carcinoma, but in that sometime with the CT scan or MRI, we can see the hypervascularization for carcinoma, but for lymphoma is hypovascularization with iso-intense picture. But for the make a good diagnosis, we just can make with the histopathological examination. Thank you.
Okay. Okay, thank you, Dr. Yuktiana. Any question? Other question?
Excuse me, Professor Nur Halim, there are some questions in the chat box. Could you
please
take this?
Yes, please.
So the question from Miss Yuniarti to Miss Ike, what the special characteristic physical and blood examination of nurse in pandemic COVID-19? Why is the result like that? Thank you.
Can I answer the question, Prof, directly? I can answer the question, Prof.
Sorry?
I can answer the question directly.
Yes, you can.
Okay,
please.
Thank you. Thank you, Prof, for the opportunity, and Dr. Yuniarti for the question. the special characteristics physical and blood examination that I found in my study, especially there is a higher body mass index. Is it result because there is because they work in shift worker, they're in shift, so there is metabolism disturbance because because discrepancy with the daily rhythm. And the other says we found that cyclic guanosine monophosphate is low in the nurse shift worker because this for the information, cyclic guanosine monophosphate is the enzyme that we can use to measure the function of the vascular. It is stated that the function of vascular of this nurse low, and also found that VO2 max or capacity aerobic capacity in this nurse also low. It may be because they're low in activity, and also because they high body mass index also. Maybe that's all, Prof, that I can answer the question.
Okay. Okay. Thank you. Okay. Any other question?
There is another question, Prof. Nur Halim.
Yes.
Yeah, the question comes from Miss Santi Rahmawati. To Dr. Yuktiana, based on your observation, what kind of multidisciplinary approach that's suitable to be conducted or performed for the similar case of DLBCL?
Okay, thank you, Ms. Santi, for the question. I would like to answer. Maybe there are a lot of multidisciplinary approach, like we need a gynecologist as a frontliner, that the first time to detect the mass on the reproductive tract of the patient, and then we need radiologists and pathologists, of course, to make a good diagnosis. And for the treatment, maybe we have to we also need the internists and to give the chemotherapy and radiotherapy properly. And for biopsy or surgery for this patient, we need a surgeon and of course the anesthesiologist. Maybe that's all the answer. Thank you.
Thank you. Okay, thank you. Still has another? For Dr. Anissa, from your presentation, did you find the related cases in Indonesia?
Yeah, thank you, Professor Nurhalim, for the questions. I think today we still don't have any data yet from cases in Indonesia related to the teratological consequences of COVID-19, unfortunately. But we are still in our project in learning more about these topics. I hope we can find some more data and significant data to conclude that is there any relations between the COVID-19 pandemics and the teratological consequences, or SARS-CoV-2 similar with other coronavirus, relatively there are no consequences of related to teratological consequences, or but some of the key points until now it is noted that the fetal neurodevelopment, the neural development disturbance is more caused because of the maternal conditions during the viral infections, not because of the virus itself. Thank you. I think that's it.
Thank you. Okay. If there is no any question anymore, thank you for the speakers, all speakers, for your presentation and give us new information.
Excuse me, Prof. Nur Halim, there is some question from Prof. Iva.
Oh, Prof. Iva, okay.
Yeah,
Yes,
Prof.
please.
Iva and Miss Santi.
Prof. Iva, we cannot hear your voice. Hello, Prof.
Yes, Prof. Iva, please.
Cannot.
When the transplantation infection influence the pregnant woman, is it first semester, second semester, or third semester?
Yes, good question.
Yeah, thank you. Can I directly answer the question, Prof. Nurhalim?
Yes, yes, please.
Okay, thank you, Prof. Iva, for the questions. I think that is the interesting points we also learned when we did this literature review, that in the first 3 semesters in the early pregnancy, the SARS-CoV-2 virus relatively use ACE2 receptors and TMPRSS2 protein to infect the placenta. But in the later pregnancy, in the late pregnancy, there are still questions and discussions because SARS-CoV-2 might be using another pathway, such as DPP4 or CD147, and then deofurin, and then trypsin, and then the other proteins. Because relatively the ACE2 and TMPRSS2 are relatively low at the later pregnancy. So, but we also observe that there are infections in late pregnancy. So I think there are another pathway that SARS-CoV-2 using to infect the placenta in the late pregnancy. Yes, it can, today it can happen in all 3 semesters, but the mechanism might be, the virus might be choose another pathway, different pathway from each 3 semesters.
Yeah. Maybe second question.
Yes.
Which organ that influence or affected by the COVID-19 infection?
Well, influence.
Which organ? Which organ?
The fetal organ or the mother's?
Fetal organ.
The fetal organ. Okay. From what we review, the most common disturbance is related to behavioral and neurological behavior growth. So the virus in the first 3 semesters mostly affect the neurodevelopmental of the fetus. I think the neurodevelopment is mostly disturbance by these infections.
I see. Yeah. Thank you, Dr. Anissa.
Thank you, Prof.
Thank you, Prof. Iva, for the question. Okay, still have other? Okay, if there is no any question anymore, please give applause to all the speakers. Thank you very much. Now, I back to the organizing committee, to the coordinator of scientific session. Please, your time.
Okay, Professor Nurhalim, thank you so much for your support in this conference and also for being with us today. Thank you so much, Prof. And then now it's the time for you as the session chair, Prof, to congratulate and also giving the e-certificate to all the presenters that already shown their best effort in presenting their papers. Please welcome Professor Nurhalim Sahib to congratulate to the presenters. Okay. So on behalf of the organizing committee, Congratulations once again to Dr. Ike Rahmawati Ali from the Medical Faculty of Unisba. Congratulations for presenting the paper. Maybe Pak Yusuf wants to continue to congratulate. Yeah. Still mute, Pak?
Welcome for the last speaker. Thank you very much to Dr. Anissa from Universitas Islam Bandung, Indonesia.
Yeah. And also congratulations to Dr. Yuktiana Karisma from the Medical Faculty of Universitas Islam Bandung. Okay, thank you so much, Dr. Anissa, for presenting the paper in the BICMHS 2021.
Once again, thank you very much to Professor Dr. Nur Halim Sahib for the greeting sharing in this session. Next, congratulations to all presenters who already presenting their papers, and also all of you already done a really good job. And finally, thank you to all audiences and participants who already participated and actively involved in giving the questions, comment, feedback, and even suggestion to the presenters. And your active participation and contribution in this scientific forum of the BICMHS is highly appreciated. And to memorize and cherish the moment, let's have a group photo together. Please turn on your Zoom video or camera in your device. And then I will start to count and take the group photo together. Okay. Please make sure your camera is on. Okay. I will start to count and take the group photo together. For the first page. Okay, for the first page, in 3, 2, 1. Okay. For the second page, in 3, 2, 1. Okay, one moment. Next page, in 3, 2, 1. Okay. And next page, in 3, 2, 1. Okay, next page, in 3, 2, 1. For the last page, in 3, 2, 1. Okay, thank you very much for all audiences, and back to Miss Santi.
Okay, thank you so much. Okay, next, before we taking a break, so allow me to read some information, the important information related to the post-conference process or the publication. Yeah. So the information for the BICMHS publication opportunity is already stated at the conference website at the bicmhs.com. So please be remembered that the timeline and also the process that the author or the presenters in this BICMHS 2021 must do in order to complete the post-conference process and also to get an international journal recommendation. So please bear in mind that the day plus 14, okay, please be remember, the day plus 14 after the conference finish you should upload your full paper or your extended paper from your current conference paper that already published in the proceedings. If you want to wish to proceed to the international journal recommendations, which is indexed by the various indexer, and it will be selected by the scientific review committee. And then, next slide, please. Yeah, so you can send your extended after make revisions. After make revision, at least 80% of your current submitted conference paper to avoid the self-plagiarism if you wish to proceed to be published in the international journals. So you should send your full paper in your ScholarVein account under the menu of upload, or you can also email the committee to info@bicmhs.com. Okay, next slide. Yeah, and before we close these sessions, in this opportunity also, we would like to invite one representative in this room to share their experience in participating at the BICMHS 2021, because we believe that the purpose of this section is to encourage others and scholars, students, academicians, and also practitioners to join the upcoming scientific forum or the conference. Okay, in this opportunity, I would like to invite Dr. Ike Rahmawati as the representative of this first session of the online presentation sessions to sharing the experience in this BICMHS 2021. Dr. Ike. Still mute, Doc?
Okay. Thank you for the opportunity, Ms. Santi, for the committee. It is very interesting conference after all, and it is the opportunity for myself also to express or to give explanation about my study. Hopefully this is useful to encourage others to make other study or further study. And thank you very much for the opportunity. Maybe that's all.
Okay, thank you so much, Dr. Ike Rahmawati, for your participation in this BICMHS 2021. Thank you. Okay, and then once again, don't forget to fill the feedback form as can be seen in the screen. And then later on also the committee will type it in the Zoom chat box. So please kindly fill the feedback forms, yeah? So we have the attendance form and also the feedback forms. Okay, back to Mr. Yusuf.
Well, thank you, Ms. Santi. And please remember to all audiences that at 4:20 p.m. we will have closing ceremony. At the closing ceremony, there will be an announcement for the best presentation category and acknowledgement for session chairs. So please ensure that all the participants stay until the end of today's conference session. And now we will have a break until 1 p.m. And once again, thank you very much for your kind attention and see you soon again at 1 p.m. Thank you.
Thank you.
Bandung City is the largest metropolitan city in West Java province, which is also known as an education city, which has a scientific treasure and has many universities. One of these is Universitas Islam Bandung, which has established since 1958, based on the ideas of several Muslim figures. As a higher education, which has an Islamic academic culture as its educational strategy, philosophically, Universitas Islam Bandung offers a comprehensive education concept based on the Islamic principles. Since its establishment, UNISBA has launched 10 faculties of bachelor degrees, or S1, as follows: Sharia, Dakwah, Tarbiyah and Teacher, Law, Psychology, Mathematics and Natural Sciences, Engineering, Economic and Business, Communication Sciences, Medical Sciences, Postgraduate programs S2, and doctoral programs S3. Support from rector, lecturers, staff, and student creativities who keep innovating in developing superior educational facilities. To support academic activities, UNISBA is stated as a major university, thus obtain an A accreditation from National Accreditation for Higher Education. Year to year, UNISBA is increasingly showing its independence to become a leading university that proven from several national and international awards. One of them, in 2019, Universitas Islam Bandung achieved the international accreditation for 14 study programs, with the highest premier assessment, which conducted by the Accreditation Service for International Schools, College, and Universities based in the UK.
Sebagai perguruan tinggi swasta berdasarkan Islam, Universitas Islam Bandung atau UNISBA memiliki nilai lebih dibanding perguruan tinggi swasta lainnya karena selalu memasukkan nilai keislaman dalam setiap aspek pengajaran, penelitian maupun pengabdian kepada masyarakat. UNISBA menjadi sebuah perguruan tinggi Islam yang memberikan kontribusi dan solusi dalam menuntaskan berbagai permasalahan yang dihadapi masyarakat dan umat. Untuk itulah UNISBA pada masa kini dan akan datang akan mendorong terwujudnya visi menjadi perguruan tinggi yang mandiri, maju dan terkemuka di Asia.
By trying to generate students as a student with 3M characters, Mujahid, Mujtahid, and Mujadid characters, to gather the superior generation with Akhlaqul Karimah, UNISBA requires its students to take a part in the Islamic boarding program for new students, Islamic boarding program for graduate prospective, the Islamic boarding program of prospective doctors. This is the expected breakthrough to answer the time challenges, competitive and competitive challenges. This is also proven from national and international achievements that achieved by students.
Fakultas Kedokteran Universitas Islam Bandung merupakan institusi pendidikan kedokteran di Indonesia yang berkomitmen menjadi institusi terdepan dalam bidang pendidikan. Fakultas Kedokteran Universitas Islam Bandung merupakan institusi pendidikan kedokteran di Indonesia yang berkomitmen menjadi institusi terdepan dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat. Fakultas Kedokteran Universitas Islam Bandung didirikan pada tanggal 27 Oktober 2004 sebagai salah satu fakultas di lingkungan Universitas Islam Bandung. Fakultas pendidikan dokter yang maju, unggul dan terkemuka berlandaskan nilai-nilai Islam di tingkat ASEAN pada tahun 2020. Sebagai bagian dari perguruan tinggi Islam, berkomitmen untuk menjadikan setiap aktivitas sebagai sarana ibadah kepada Allah Subhanahu wa Ta'ala.
Fakultas Kedokteran Universitas Islam Bandung telah berhasil mendapatkan akreditasi baik pada tingkat nasional maupun tingkat internasional. Pada tingkat nasional, FKUnisba berhasil mendapatkan akreditasi A dari Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan. Sedangkan di tingkat internasional, FKUnisba berhasil mendapatkan akreditasi Premier dari Accreditation Service for International College yang merupakan salah satu lembaga akreditasi dari Inggris. Didukung dengan 12 guru besar, 125 tenaga pendidik atau dosen lainnya, kemudian 34 tenaga kependidikan, 26 departemen preklinik dan klinik, serta 6 pusat riset penelitian.
Didukung dengan fasilitas laboratorium anatomi, histologi, biometrik, dan laboratorium penelitian yang terintegrasi.
Rumah Sakit Pendidikan Utama Al-Ihsan Bandung, Rumah Sakit Al-Islam Bandung, Rumah Sakit Muhammadiyah Bandung, Rumah Sakit Jiwa Provinsi Daerah Jawa Barat, Cisarua, Rumah Sakit Angkatan Udara Dr. Salamun, Rumah Sakit Bayangkara Sartika Asih Bandung, Rumah Sakit Umum Daerah Cibabat Kota Cimahi, Rumah Sakit Umum Daerah Dr. Slamet Kabupaten Garut, dan Rumah Sakit Umum Daerah Samsudin SH Kota Sukabumi.
Fakultas Kedokteran Universitas Islam Bandung juga mengembangkan dan meningkatkan pendidikan kedokteran berkelanjutan melalui kegiatan kuliah tamu, seminar, simposium, dan lokakarya.
Di samping itu, Fakultas Kedokteran Universitas Islam Bandung juga didukung oleh tim dan fasilitas teknologi informasi yang terintegrasi dengan sistem yang ada di universitas. Fasilitas perkuliahan dalam jaringan, video conference, webinar, dan sistem informasi manajemen akademik juga sudah disiapkan. Ruangan yang didukung fasilitas komputer lengkap dengan kapasitas lebih dari 200 unit menciptakan suasana kampus yang nyaman dan selaras dengan perkembangan teknologi. Didukung dengan ruang kerja yang nyaman, museum, perpustakaan, fasilitas olahraga, dan bangunan yang ramah untuk difabel.
Kerjasama dan kolaborasi yang baik dari seluruh sivitas akademika Fakultas Kedokteran Universitas Islam Bandung dan mitra strategis telah melahirkan manfaat yang besar dan penguatan dalam aspek pendidikan, penelitian, dan pengabdian masyarakat sebagai perwujudan tridharma perguruan tinggi. Kerjasama internasional telah menjadi sarana bagi pertukaran staf pengajar maupun mahasiswa.
Kami siap bersinergi dan berkolaborasi untuk memberikan sumbangsih terbaik bagi umat dan bangsa. FKUnisba
maju dan terkemuka.
Secara umum, kegiatan pembelajaran di tahap akademik ini terdiri dari kuliah kecil dan kuliah kelas besar. Pada kuliah kecil terdiri dari tutorial, skill lab, dan lab activity. Tutorial merupakan proses pembelajaran di mana terdiri dari 10 orang mahasiswa dalam satu kelompok didampingi oleh satu orang dosen atau tutor. Sedangkan skill lab ini merupakan laboratorium keterampilan klinis di mana mahasiswa diproses untuk memahami sampai mereka mahir dalam satu keterampilan klinis. Kemudian lab activity adalah merupakan proses pembelajaran yang tujuannya adalah untuk penguatan kesan terhadap learning issue sistem yang sedang berjalan. Kemudian untuk kelas besar terdiri dari lecture dan meet the expert. Kelas besar ini tidak terbahas di dalam tutorial atau di dalam learning activity. Sedangkan meet the expert dilakukan apabila seluruh learning issue itu tidak terbahas di semua kegiatan, baru kita melakukan meet the expert. Sedangkan ujian-ujian terdiri dari student objective oral case analysis atau SOTA dan CBT atau computer based test. Sedangkan pada masa pandemi ini ada satu ujian yang tidak bisa dilakukan, yaitu OSCE, karena itu merupakan keterampilan klinis yang harus bertemu langsung dengan mahasiswa.
FKUnisba mulai tahun 2008 melaksanakan program studi pendidikan dokter dengan menerapkan kurikulum berbasis kompetensi melalui proses belajar hingga mahir atau mastery learning. Pendekatan mastery learning dikembangkan pada prinsip belajar orang dewasa yang lebih bersifat self-directed learning, partisipatif, relevan, dan praktis. Melalui pendekatan ini, diharapkan mahasiswa tahap profesi akan dapat menguasai pengetahuan, keterampilan, perilaku, dan etika yang dibutuhkan dalam rangka menjalankan profesi dokter. Adanya pandemi membuat program studi mengalami perubahan metode pembelajaran yaitu secara blended, yaitu dengan daring dan luring. Tentunya seluruh dokter muda sebelum luring atau masuk ke panitiaan di rumah sakit sudah terscreening dengan rapid test swab antigen dengan PCR. Dan pada masing-masing ruang pembelajaran seperti di ruang rawat jalan dan di ruang rawat inap menggunakan APD level 1, sedangkan pembelajaran di instalasi gawat darurat dan kamar operasi menggunakan APD level 2 dan 3.
Recording stopped.
Bandung City is the largest metropolitan city in West Java province, which is also known as an education city, which has a scientific treasure and has many universities. One of these is Universitas Islam Bandung, which has established since 1958, based on the ideas of several Muslim figures. As a higher education, which has an Islamic academic cultures as its educational strategy, philosophically, Universitas Islam Bandung offers a comprehensive education concept based on the Islamic principles. Since its establishment, UNISBA has launched 10 faculties of bachelor degrees, or S1, as follows: Sharia, Dakwah, Tarbiyah and Teacher, Law, Psychology, Mathematics and Natural Sciences, Engineering, Economic and Business, Communication Sciences, Medical Sciences, Postgraduate Programs S2, and Doctoral Programs S3. Support from Rector, lecturers, staff, and student creativities who keep innovating in developing superior educational facilities. To support academic activities, UNISBA is stated as a major university, thus obtained an A accreditation from National Accreditation for Higher Education. Year to year, UNISBA is increasingly showing its independence to become a leading university that proven from several national and international awards. One of them, in 2019, Universitas Islam Bandung achieved the international accreditation for 14 study programs, with the highest premier assessment, which conducted by the Accreditation Service for International Schools, College, and Universities based in the UK.
Sebagai perguruan tinggi swasta berdasarkan Islam, Universitas Islam Bandung atau UNISBA memiliki nilai lebih dibanding perguruan tinggi swasta lainnya karena selalu memasukkan nilai keislaman dalam setiap aspek pengajaran, penelitian maupun pengabdian kepada masyarakat. UNISBA menjadi sebuah perguruan tinggi Islam yang memberikan kontribusi dan solusi dalam menuntaskan berbagai permasalahan yang dihadapi masyarakat dan umat. Untuk itulah UNISBA pada masa kini dan akan datang akan mendorong terwujudnya visi menjadi perguruan tinggi yang mandiri, maju dan terkemuka di Asia.
By trying to generate students as a student with 3M characters, Mujahid, Mujtahid, and Mujadid characters. Together the superior generation with Akhlaqul Karimah, Unisba requires its students to take a part in the Islamic boarding program for new students, Islamic boarding program for graduate prospective, the Islamic boarding program of prospective doctors. This is the expected breakthrough to answer the time challenges, competitive and competitive challenges. This is also proven from national and international achievements that achieved by students.
Fakultas Kedokteran Universitas Islam Bandung merupakan institusi pendidikan kedokteran di Indonesia yang berkomitmen menjadi institusi terdepan dalam bidang pendidikan, penelitian, dan pengabdian pada masyarakat. Fakultas Kedokteran Universitas Islam Bandung didirikan pada tanggal 27 Oktober 2004 sebagai salah satu fakultas di lingkungan Universitas Islam. Fakultas Kedokteran Universitas Islam Bandung memiliki visi menjadi program studi pendidikan dokter yang maju, unggul, dan terkemuka berlandaskan nilai-nilai Islam di tingkat ASEAN pada tahun 2025. Sebagai bagian dari perguruan tinggi Islam, berkomitmen untuk menjadikan setiap aktivitas sebagai sarana ibadah kepada Allah Subhanahu wa Ta'ala.
Fakultas Kedokteran Universitas Islam Bandung telah berhasil mendapatkan akreditasi baik pada tingkat nasional maupun tingkat internasional. Pada tingkat nasional, FKUnisba berhasil mendapatkan akreditasi A dari Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan. Sedangkan di tingkat internasional, FKUnisba berhasil mendapatkan akreditasi Premier dari Accreditation Service for International College yang merupakan salah satu lembaga akreditasi dari Inggris. Didukung dengan 12 guru besar, 125 tenaga pendidik atau dosen lainnya, kemudian 34 tenaga kependidikan, 26 departemen preklinik dan klinik, serta 6 pusat riset penelitian.
Didukung dengan fasilitas laboratorium anatomi, histologi, biometrik, dan laboratorium penelitian yang terintegrasi.
Rumah Sakit Pendidikan Utama Al-Ihsan Bandung, Rumah Sakit Al-Islam Bandung, Rumah Sakit Muhammadiyah Bandung, Rumah Sakit Jiwa Provinsi Daerah Jawa Barat, Cisarua, Rumah Sakit Angkatan Udara Dr. Salamun, Rumah Sakit Bayangkara Sartika Asih Bandung, Rumah Sakit Umum Daerah Cibabat Kota Cimahi, Rumah Sakit Umum Daerah Dr. Slamet Kabupaten Garut, dan Rumah Sakit Umum Daerah Samsudin SH Kota Sukabumi.
Fakultas Kedokteran Universitas Islam Bandung juga mengembangkan dan meningkatkan pendidikan kedokteran berkelanjutan melalui kegiatan kuliah tamu, seminar, simposium, dan lokakarya.
Di samping itu, Fakultas Kedokteran Universitas Islam Bandung juga didukung oleh tim dan fasilitas teknologi informasi yang terintegrasi dengan sistem yang ada di universitas. Fasilitas perkuliahan dalam jaringan, video conference, webinar, dan sistem informasi manajemen akademik juga sudah disiapkan. Ruangan yang didukung fasilitas komputer lengkap dengan kapasitas lebih dari 200 unit menciptakan suasana kampus yang nyaman dan selaras dengan perkembangan teknologi. Didukung dengan ruang kerja yang nyaman, museum, perpustakaan, fasilitas olahraga, dan bangunan yang ramah untuk difoto.
Kerjasama dan kolaborasi yang baik dari seluruh sivitas akademika Fakultas Kedokteran Universitas Islam Bandung dan mitra strategis telah melahirkan manfaat yang besar dan penguatan dalam aspek pendidikan, penelitian, dan pengabdian masyarakat sebagai perwujudan tridharma perguruan tinggi. Kerjasama internasional telah menjadi sarana bagi pertukaran staf pengajar maupun mahasiswa.
Kami siap bersinergi dan berkolaborasi untuk memberikan sumbangsih terbaik bagi umat dan bangsa. FKUnisba maju dan terkemuka.
Kegiatan pembelajaran di tahap akademik ini terdiri dari kuliah kecil dan kuliah kelas besar. Pada kuliah kecil terdiri dari tutorial, skill lab, dan lab activity. Tutorial merupakan proses pembelajaran di mana terdiri dari 10 orang mahasiswa dalam satu kelompok didampingi oleh satu orang dosen atau tutor. Sedangkan skill lab ini merupakan laboratorium keterampilan klinis di mana mahasiswa diproses untuk memahami sampai mereka mahir dalam satu keterampilan klinis. Kemudian lab activity adalah merupakan proses pembelajaran yang tujuannya adalah untuk penguatan kesan terhadap learning issue sistem yang sedang berjalan. Kemudian untuk kelas besar terdiri dari lecture dan meet the expert. Kelas besar ini dilakukan di dalam kelas besar dengan satu orang dosen akan membahas teori-teori atau ilmu-ilmu yang tidak terbahas di dalam tutorial atau di dalam lab activity. Sedangkan meet the expert dilakukan apabila seluruh learning issue itu tidak terbahas di semua kegiatan, baru kita melakukan meet the expert. Sedangkan ujian-ujian terdiri dari student objective case analysis atau SOTA dan CBT atau computer based test. Sedangkan pada masa pandemi ini ada satu ujian yang tidak bisa dilakukan, yaitu post-check, karena itu merupakan keterampilan klinis yang harus bertemu langsung dengan mahasiswa. FKUnisba mulai tahun 2008 melaksanakan program studi pendidikan dokter dengan menerapkan kurikulum berbasis kompetensi melalui proses belajar hingga mahir atau mastery learning. Pendekatan mastery learning dikembangkan pada prinsip belajar orang dewasa yang lebih bersifat self-directed learning, partisipatif, relevan, dan praktis. Melalui pendekatan ini, diharapkan mahasiswa tahap profesi akan dapat menguasai pengetahuan, keterampilan, perilaku, dan etika yang dibutuhkan dalam rangka menjalankan profesi dokter. Adanya pandemi membuat program studi mengalami perubahan metode pembelajaran, yaitu secara blended, yaitu dengan daring dan luring. Tentunya seluruh dokter muda sebelum luring atau masuk ke paniteraan di rumah sakit sudah terscreening dengan rapid test swab antigen dengan PCR. Dan pada masing-masing ruang pembelajaran seperti di ruang rawat jalan dan di ruang rawat inap menggunakan APD level 1, sedangkan pembelajaran di instalasi gawat darurat dan kamar operasi menggunakan APD level 2 dan 3.
Bandung City is the largest metropolitan city in West Java province, which is also known as an education city, which has a scientific treasure and has many universities. One of these is Universitas Islam Bandung, which has established since 1958, based on the ideas of several Muslim figures. As a higher education, which has an Islamic academic culture as its educational strategy, philosophically, Universitas Islam Bandung offers a comprehensive education concept based on the Islamic principles. Since its establishment, UNISBA has launched 10 faculties of bachelor degrees, or S1, as follows: Sharia, Dakwah, Tarbiyah and Teacher, Law, Psychology, Mathematics and Natural Sciences, Engineering, Economic and Business, Communication Sciences, Medical Sciences, Postgraduate programs S2, and doctoral programs S3. Support from rector, lecturers, staff, and student creativities who keep innovating in developing superior educational facilities. To support academic activities, UNISBA is stated as a major university, thus obtain an A accreditation from National Accreditation for Higher Education. Year to year, UNISBA is increasingly showing its independence to become a leading university that proven from several national and international awards. One of them, in 2019, Universitas Islam Bandung achieved the international accreditation for 14 study programs, with the highest premier assessment, which conducted by the Accreditation Service for International Schools, Colleges, and Universities based in the UK.
Sebagai perguruan tinggi swasta berdasarkan Islam, Universitas Islam Bandung atau UNISBA memiliki nilai lebih dibanding perguruan tinggi swasta lainnya karena selalu memasukkan nilai keislaman dalam setiap aspek pengajaran, penelitian maupun pengabdian kepada masyarakat. UNISBA menjadi sebuah perguruan tinggi Islam yang memberikan kontribusi dan solusi dalam menuntaskan berbagai permasalahan yang dihadapi masyarakat dan umat. Untuk itulah UNISBA pada masa kini dan akan datang akan mendorong terwujudnya visi menjadi perguruan tinggi yang mandiri, maju dan terkemuka di Asia.
By trying to generate students as a student with 3M characters, Mujahid, Mujtahid, and Mujadid characters, together the superior generation with Akhlaqul Karimah, UNISBA requires its students to take a part in the Islamic boarding program for new students, Islamic boarding program for graduate prospective, the Islamic boarding program of prospective doctors. This is the expected breakthrough to answer the time challenges, competitive and competitive challenges. This is also proven from national and international achievements that achieved by students.
Fakultas Kedokteran Universitas Islam Bandung merupakan institusi pendidikan kedokteran di Indonesia yang berkomitmen menjadi institusi terdepan dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat. Fakultas Kedokteran Universitas Islam Bandung didirikan pada tanggal 27 Oktober 2004 sebagai salah satu fakultas di lingkungan Universitas Islam. Fakultas Kedokteran Universitas Islam Bandung memiliki visi menjadi program studi pendidikan dokter yang maju, unggul dan terkemuka berlandaskan nilai-nilai Islam di tingkat ASEAN pada tahun 2020. Sebagai bagian dari perguruan tinggi Islam berkomitmen untuk menjadikan setiap aktivitas sebagai sarana ibadah kepada Allah Subhanahu wa Ta'ala.
Fakultas Kedokteran Universitas Islam Bandung telah berhasil mendapatkan akreditasi baik pada tingkat nasional maupun tingkat internasional. Pada tingkat nasional, FKUnisba berhasil mendapatkan akreditasi A dari Lembaga Akreditasi Mandiri Perguruan Tinggi Kesehatan. Sedangkan di tingkat internasional, FKUnisba berhasil mendapatkan akreditasi Premier dari Accreditation Service for International College yang merupakan salah satu lembaga akreditasi dari Inggris. Didukung dengan 12 guru besar, 125 tenaga pendidik atau dosen lainnya, kemudian 34 tenaga kependidikan, 26 departemen preklinik dan klinik, serta 6 pusat riset penelitian.
Didukung dengan fasilitas laboratorium, anatomi, histologi, biometrik, dan laboratorium penelitian yang terintegrasi.
Rumah Sakit Pendidikan Utama Al-Ihsan Bandung, Rumah Sakit Al-Islam Bandung, Rumah Sakit Muhammadiyah Bandung, Rumah Sakit Jiwa Provinsi Daerah Jawa Barat, Cisarua, Rumah Sakit Angkatan Udara Dr. Salamun, Rumah Sakit Bayangkara Sartika Asih Bandung, Rumah Sakit Umum Daerah Cibabat Kota Cimahi, Rumah Sakit Umum Daerah Dr. Slamet Kabupaten Garut, dan Rumah Sakit Umum Daerah Samsudin SH Kota Sukabumi.
Fakultas Kedokteran Universitas Islam Bandung juga mengembangkan dan meningkatkan pendidikan kedokteran berkelanjutan melalui kegiatan kuliah tamu, seminar, simposium, dan lokakarya.
Di samping itu, Fakultas Kedokteran Universitas Islam Bandung juga didukung oleh tim dan fasilitas teknologi informasi yang terintegrasi dengan sistem yang ada di universitas. Fasilitas perkuliahan dalam jaringan, video conference, webinar, dan sistem informasi manajemen akademik juga sudah disiapkan. Ruangan yang didukung fasilitas komputer lengkap dengan kapasitas lebih dari 200 unit menciptakan suasana kampus yang nyaman dan selaras dengan perkembangan teknologi. Didukung dengan ruang kerja yang nyaman, museum, perpustakaan, fasilitas olahraga, dan bangunan yang ramah untuk difabel.
Kerjasama dan kolaborasi yang baik dari seluruh sivitas akademika Fakultas Kedokteran Universitas Islam Bandung dan mitra strategis telah melahirkan manfaat yang besar dan penguatan dalam aspek pendidikan, penelitian, dan pengabdian masyarakat sebagai perwujudan tridharma perguruan tinggi. Kerjasama internasional telah menjadi sarana bagi pertukaran staf pengajar maupun mahasiswa.
Kami siap bersinergi dan berkolaborasi untuk memberikan sumbangsih terbaik bagi umat dan bangsa. FKUnisba
maju dan terkemuka.
Secara umum, kegiatan pembelajaran di tahap akademik ini terdiri dari kuliah kecil dan kuliah kelas besar. Pada kuliah kecil terdiri dari tutorial, skill lab, dan lab activity. Tutorial merupakan proses pembelajaran di mana terdiri dari 10 orang mahasiswa dalam satu kelompok didampingi oleh satu orang dosen atau tutor. Sedangkan skill lab ini merupakan laboratorium keterampilan klinis di mana mahasiswa diproses untuk memahami sampai mereka mahir dalam satu keterampilan klinis. Kemudian lab activity adalah merupakan proses pembelajaran yang tujuannya adalah untuk penguatan kesan terhadap learning issue sistem yang sedang berjalan. Kemudian untuk kelas besar terdiri dari lecture dan meet the expert. Kelas besar ini dilakukan di dalam kelas besar dengan satu orang dosen akan membahas teori-teori atau ilmu-ilmu yang tidak terbahas di dalam tutorial atau di dalam lab activity. Sedangkan meet the expert dilakukan apabila seluruh learning issue itu tidak terbahas di semua kegiatan, baru kita melakukan meet the expert. Sedangkan ujian-ujian terdiri dari student objective oral case analysis atau SOCA dan CBT atau computer based test. Sedangkan pada masa pandemi ini ada satu ujian yang tidak bisa dilakukan, yaitu OSCE, karena itu merupakan
FKUnisba mulai tahun 2008 melaksanakan program studi pendidikan dokter dengan menerapkan kurikulum berbasis kompetensi melalui proses belajar hingga mahir atau mastery learning. Pendekatan mastery learning dikembangkan pada prinsip belajar orang dewasa yang lebih bersifat self-directed learning, partisipatif, relevan, dan praktis. Melalui pendekatan ini, diharapkan mahasiswa tahap profesi akan dapat menguasai pengetahuan, keterampilan, perilaku, dan etika yang dibutuhkan dalam rangka menjalankan profesi dokter. Adanya pandemi membuat program studi mengalami perubahan metode pembelajaran yaitu secara blended, yaitu dengan daring dan luring. Tentunya seluruh dokter muda sebelum luring atau masuk ke paniteraan di rumah sakit sudah terscreening dengan rapid test swab antigen dengan PCR. Dan pada masing-masing ruang pembelajaran seperti di ruang rawat jalan dan di ruang rawat inap menggunakan APD level 1, sedangkan pembelajaran di instalasi gawat darurat dan kamar operasi menggunakan APD level 2 dan 3.
Cek, cek.
Recording in progress.
Check, check, check one. Should we start?
Yes, Pak.
Well, ladies and gentlemen, distinguished participants and attendees, welcome back again to BICMHS 2021. Let us move to the next session. The second plenary session is Professor Dr. Omar Hasan Kasule. Are you here, Professor Omar? Have you joined us?
Yeah, I have joined. I'm here already.
Okay, thank you. Well, the second plenary speaker is Professor Dr. Omar Hasan Kasule from King Fahd University, Saudi Arabia. This plenary speaker session will be moderated by Ibu Mia Kusmiati, Dr. MPD, Kedokteran Ph.D, and Ibu Eka Nurhayati, Dr. MKM. And before the session begin, I would like to read the moderator profile and plenary speaker profile.
Okay. Before that, excuse me, Professor Omar.
Yes.
Yes. So before you start sharing the screen, allow us to read your profile first.
Okay.
Okay, hold on. Yeah, hold on, it's still loading.
Okay.
So once again, welcome Professor Omar to the Bandung International Conference on Medical and Health Sciences. And this is the first day, Prof. And tomorrow we still have one more day for the BICMHS. Okay, hold on, let me check. Just hold, wait a minute. Yeah, okay. We will wait for a while, just hold on for a while. Okay, okay, okay. Let me share the screen. Yeah, please continue, Pak Yusuf, maybe from introducing the moderators.
Okay.
Yeah.
Well, once again, before the session began, I would like to read the moderator profile and plenary speakers profile. Yeah. For the moderator is Dr. Mia Kusmiati, is a senior lecturer in the Faculty of Medicine, Universitas Islam Bandung, Indonesia. She is freshly finishing a doctorate program in medical education from University of Cyberjaya, Malaysia. And also she is currently assigned the position of Chairman of Medical Education Unit in Medical Faculty in Universitas Islam Bandung, and also holding as a head of Department Medical Education, Bioethic and Humanity, and also her research interests are regarding curriculum evaluation, assessment of professionalism, and teaching learning behavior. Her works had been published in some international journals, Scopus Indexing, such KJME, Medical Science Educator Journal, and National Journal Sinta Indexing. She has involved in various training and workshop for enhancing pedagogical competence of medical teacher as a research person, also for faculty development. And before that, Dr. Mia was holding as chairman of undergraduate medical education in 2012 until 2016 at the same university in which she works now. And for the second moderator, we have Ibu Eka Nurhayati. Ibu Eka Nurhayati is one of public health lecturers from Universitas Islam Bandung, Indonesia, and she graduated from Faculty of Medicine, Universitas Kristen Maranatha, Indonesia, and her master degree in public health from Universitas Pajajaran, Indonesia. She was once worked in Puskesmas Air Sugihan Jalur 27, South Sumatra, before enlisted in Universitas Islam Bandung, Indonesia. She was holding as secretary of undergraduate program, Faculty of Medicine, UNISBA, in 2016 until 2020. And currently, she is the second year of doctoral program from Faculty of Public Health, Universitas Erlangga, Indonesia, and also her interest is on health policy and mental health. And now, to the moderator, Dr. Mia Kusmiati, and also Dr. Eka Nurhayati, MKM, the time is yours to lead the plenary session.
Okay, thank you, Mr. Ahmad Yusuf, for my time. The first, I would like to greet the Prof. Omar Kasule. Prof, Assalamualaikum, Prof. Welcome to Bandung International Conference on Medical and Health Sciences. Thank you, Prof. Before we start to the presentation, Prof. Omar Hasan Kasule, kindly to read or to state the curriculum vitae or short profile. Professor Dr. Omar Hasan Kasule from King Fahd University, Saudi Arabia. He is a physician holding a doctorate in epidemiology from Harvard University. He is currently a professor of epidemiology and bioethics at the King Fahd Medical City in Riyadh, Saudi Arabia. Prof. Omar is also chairman of Research Ethics at Princess Noura University, as well as the King Abdullah bin Abdul Aziz University Hospital in Riyadh, Saudi Arabia. Before Saudi Arabia, he served as a professor in the Fakultas of Medicine at the University of Brunei and the International Islamic University in Malaysia, or we call them the IIUM. Before that, Prof. Omar was a teaching fellow at Harvard University and a consultant in epidemiology and clinical quality assurance in Virginia. While in Malaysia, he pioneered the integration of Islamic value in the medical curriculum. And he also has so many articles that been published, and maybe the audience can see in the slide or his writing accessible if something like this. And ladies and gentlemen, we will start for the presentation of the Professor Omar Hasan Kasule. The audience, may I have your attention, please, because the presentation is about to begin. First of all, I would like to welcome you all to this second plenary session. In this occasion, we would like to presentation Prof. Omar Hasan Kasule that will deliver regarding Islamic bioethics, sources of conflicts and balance. All right, Prof, you have, I need to inform you that you have time in 30 minutes. And after that, we continue to Q&As. The floor is yours, Prof. Please.
Bismillahirrahmanirrahim. Wassalatu wassalam ala Rasulillah. It's a pleasure for me to be with you today and in this Zoom meeting. Inshallah, I hope that one day I will be able to come and we meet in person in Bandung. I've been to Bandung before. It's a beautiful city. I hope you see my screen. Do you see my screen?
Yes, Prof. Yes.
Great. Inshallah, we'll go ahead. Now, the summary of my talk is that Islamic bioethics is under the Sharia. It's part of the Sharia.
Excuse me, Prof. You can show the slideshow. Because still not slideshow.
You don't see the screen?
Yes, but still not slideshow. Maybe you can click the.
No. If you can see, it's better this way. You know, my system has some problem. If I make it slideshow, it has problems.
Okay, no problem, Prof. Okay.
So, as I say, bioethics is part of the Sharia, and it follows the 5 maqasid al-Sharia and the Qawa'id al-Fiqh. Now, we understand ethics better as ethical dilemmas when somebody has got conflicting choices and you have to choose which one is the right one. And whatever you choose has got problems and responsibilities and principles. Now, some dilemmas can be solved by fiqh rulings, but others require additional analysis using maqasid and qawa'id. Now, most of bioethics revolves around the purpose of life, preserving human life. Now, I have got a small problem with the term ethics because I need to apologize. I'm using the word ethics because this is the English language and the people we deal with use this term. But strictly speaking, we do not have the word ethics in Islam. We have Sharia, because Sharia goes under ethics. So we don't have to have a separate discipline. And all ethical issues are Sharia issues and can be resolved using the Sharia, because ethical is the same as moral, you know, and is the same as legal. So what is halal is ethical, what is haram is unethical. There's some other terminologies that I use, like akhlaq al-tabib or adab al-tabib. These have got a wider connotation than medical or health ethics. Now, the fear of ethics
based on Maqasid al-Sharia. This theory was first presented at a conference in Jordan in 2004 in 2 papers, one on medical ethics, one on research ethics. Now, Maqasid and Qawaid are from Naqal, they are from Quran and Sunnah, and derived inductively from these primary sources of the Quran. So the Maqasid provide a general theory to guide us, while Qawaid give us detailed tools for reasoning out ethical dilemmas. Now, let me say the 5 objectives of the Sharia. In order for a medical procedure to be considered ethical, it must conform to or not violate the 5 objectives of the Sharia. And they are Hifz al-Din, protect morality or protect religion. Hifz al-Nafs, protect life and health, which is the major work of medicine. Hifz al-Nasl, protect the progeny, so lineage and reproduction. So obstetrics, gynecology, pediatrics all fall under this objective. Hifz al-Aql, protect the human mind. So psychology, psychiatry, treatment of addictions fall under this to protect the mind, the intellect. And Hifz al-Mal, this is about medical resources. So any problem that you meet can be referred to one of these purposes of the Sharia. Now, in addition to the purposes, which are a wide theory, we have got the principles of fiqh. These ones operationalize the maqasid. We use this to put the maqasid in practice. The first one is principle of intention, qa'idat al-qasd. This says that whatever you do is judged by the niyyah, the underlying intention. Al-umur maqasidiha. A lot of times we do things that are correct according to the textbook, but our niyyah inside is different. So you want to make sure that what you do is actually what is inside you, that there is no conflict between the inside and the outside. The second principle is qa'idat al-yaqeen, the principle of certainty. This says that whatever you do must be based on evidence. This is the basis of evidence-based practice. For us as Muslims, we don't learn this already in our fiqh, that we must have evidence from history taking, examination, investigation before we make decisions. The third principle is the principle of harm, qa'idat al-darar. This means that any intervention, we need to look at the benefits of that intervention, of that medical procedure, and maximize the benefits. And then we need to look at the side effects, because every procedure has got side effects. We must minimize the side effects. So this is the principle of darar, principle of harm. Principle of difficulty, qa'idat al-mashaqqa, it says that in situations of difficulty, we make exceptions to existing regulations because of darura. For example, it's not allowed to look at the aura of another person, especially of the opposite gender. But if there's a darura, a necessity of medical treatment, that can be allowed under this principle of mashaqqa. The last principle is the principle of precedent, qa'idat al-urf, or 'ada. This means that when we practice, we must follow the procedures, the standard procedures that are accepted in the profession. We should not do things based on our whims. We must follow the 'ada, we must follow the established procedures. Now, I have talked about the theory and the principles of ethics that we follow. And I just want to tell you that the Western principles of ethics, which are 4, autonomy, beneficence,
non-maleficence, and just. All four just fit in only one principle of darar, qa'idat al-darar. So our system is much wider than the Western or European system. Now, when we deal with ethics, really it's ethical dilemmas because we are not sure what to do. And in an ethical dilemma, there are conflicting considerations. So we need to reason out the dilemma using naqal and aqal. Naqal means knowledge transmitted, Quran and Sunnah, and aqal using our human mind and experience. So the ethical dilemmas can be either a right against a responsibility, or can be a right against a right, haq against haq, responsibility against responsibility. Purpose, it is always some sort of conflict between two things. So, and we need to find a solution to that dilemma using the maqasid and the qawa'id. So now let us look at examples of these conflicts. Sometimes when we have a conflict, we need to solve it by balancing the conflicts. You cannot solve them. For example, somebody is in the ICU. The principle says, the maqsad says, hifdh al-nafs, you must protect life. But then, when they stay too long in the ICU with no hope of cure, maybe you are wasting resources. So this is a conflict between life and resources. How do you resolve it? That's when we resort to the maqasid and qawa'id and to solve them. In reality, we may see conflicts, but these are actually apparent. See, the Sharia is consistent. They are apparent and not real, because like life is not really opposed to costs. It's an apparent conflict. And when we go into it, we can balance the two in a correct way. Now, as I said, for a terminal patient in intensive care, we must preserving health, balance preserving health, hifdh al-nafs, against preserving resources. But then, how do we do that? Well, we can use the qawa'id, qa'idat al-yaqeen, the principle of certainty. Are we sure there is life anymore? Because sometimes somebody is in ICU and is already brain dead. So now that conflict is solved. We remove the life support. Now, sometimes you may have a conflict, like the purpose of preserving religion. Hifdh al-din, Sawm is part of hifdh al-din. It may conflict with the purpose of preserving health, hifdh al-nafs. If Sawm has got adverse effects on the health of the sick. Again, this can be resolved by looking at minimizing the harm of Sawm on the sick, or puasa. Sawm is the same as puasa on the sick person, or completely excusing them from puasa. So you can solve that ethical conflict. In in vitro fertilization, we have got a conflict between the purpose of progeny, hifdh al-nasl. We need to reproduce children. But then this may conflict with the purpose of life, hifdh al-nafs, because we use ova, we fertilize the ova, and the extra ones are destroyed. Remember, once an ovum is fertilized, that is life. So when you destroy it, you're destroying life. So you have a conflict. On the one hand, you want to do in vitro fertilization to be able to have children, but in the process, you may be destroying life. So that's an ethical conflict that has to be resolved. That first of all, try not to have many extra ova. Some people say do fertilize one every cycle. And some people say that some ulama allow that they can be used for research or other purposes. This is a detailed fatwa. So that conflict can be resolved. There is the principle of yaqeen. I told you everything we do must be based on certainty, yaqeen. Now, this has to be balanced against the principle of life, because sometimes you've got a very sick person with a severe infection and you need to give an antibiotic, but you don't yet have the culture and sensitivity to give the correct antibiotic. So what do? Do you wait? When you wait, he will get worse. So you make the best judgment and treat empirically. So the principle of certainty here is compromised, at least for a short time, because we need to save life. So ethics is always like this. You have got two conflicting things and you want to resolve them. Now, let us talk about the principle of harm, qaidatul darar. In the principle of harm, you want to balance benefits of a medical procedure or an intervention against the adverse outcomes or bad outcomes. Every medical intervention has got benefits. It also has got side effects. No procedure is 100% benefit or 100% bad. So we need to reason out and see what to do. If the benefits are much more than the adverse outcomes, we go ahead and do the procedure. But if the adverse outcomes are more than the benefits, then we do not do it. I already gave the example that we can terminate life support in the ICU when there is certainty of death as assessed by brain death criteria. So there are many tools that we can use to resolve conflicts. The important thing is to know that ethics always involves conflicts between two considerations. Now, let me talk about balancing rights and responsibilities. The treating physician has a responsibility to protect the health of the patient, okay? But also, he has the responsibility to uphold the patient's right autonomy. Remember, a patient must have the right autonomy to make decisions about his care. So here you as a physician, on one side, you want to respect the patient's autonomy, but then you think that he's making a mistake in his decision, and it's your responsibility to protect his life. This is very tricky, very difficult. In fact, it has become so difficult that some people say we should restrict patient autonomy, sometimes in the interest of the patient, that it shouldn't be absolute autonomy. This is a situation when responsibility and patient right are in conflict. Another case, if you've got a terminal patient, somebody who is very sick and refuses treatment, he has his right to autonomous decision. You know, we must respect the decision of the patient. But then he has responsibility. That patient has got a responsibility, wajib, to Allah subhanahu wa ta'ala to protect his body and his health. So when he refuses treatment, he's using his right of autonomy to decide, but he's violating his responsibility to protect his body and his health. So this is a conflict, and we may need to explain the principles to the patient so that we can find a solution to this. A medical researcher also must balance his responsibility to scientific knowledge. A medical researcher has responsibility to produce scientific knowledge, but then that may be in conflict with the responsibility to care for patients, because you cannot do both at the same time. Sometimes you may spend more time on research and less on the patient care. If you spend more on patient care, you may do less research. So you need to resolve this dilemma, this conflict. So ethics or bioethics in the end is about finding a balance. And as I said, we have to use maqasid al-sharia, the 5 maqasid, and qawaid al-fiqh, the 5 principles, to find a solution and make reasoning. Now, I'll give you another example. A medical administrator, the head of the hospital, must balance his responsibility to provide the best cure to the patient. But then he has got another responsibility to control costs and balance the budget of the hospital. So what do? Do you give the most expensive, most effective antibiotic? But then the hospital will have financial problems. So how do you balance this? We have already talked about a terminal patient in the intensive care unit, but now let us talk about a different dilemma. He has got a right to life for the nafs by being in the ICU as long as possible. It's very expensive. But then this conflicts with the right of other patients, because the other patients, they have had a car accident, they need to be admitted. They cannot be admitted because this person is on this bed. So sometimes we may need to make a decision between the two. So the maqasid and qawaid help us in solving these problems. The point I want to make is that bioethics is about conflicting rights, conflicting responsibilities, conflicting duties. And the solution is always difficult. But in the end, we need to strike a balance between the conflicting things. And the maqasid and qawaid, our way of finding this balance. Now, in the last part of my presentation, I want to emphasize the centrality of the purpose of life, hifdh al-nafs. In all what we do in bioethics, we want to protect life, because life and health belong to Allah subhanahu wa ta'ala. He's the one who gives them, he's the one who takes them away. But as humans, a human is a temporary custodian of his life and health. So he has a duty to protect them as much as we can. So I just want to make it very clear from the point of view of Aqidah, our duty is to protect health, preserve health, and not life. See, we do whatever we can to get the best quality of life, but the quantity of life, when somebody will die, that's in the hands of Allah subhanahu wa ta'ala. We cannot control death. So you must be very clear about this matter. It's about quality of life, but you cannot stop death. So our duty is to give the best quality of care until the time of death occurs, because we cannot delay the death. And we need to know that humans only die once. We cannot return back to earthly life. When somebody dies, they have died. It's very important to know this. There's no reincarnation. Disease and treatment are in the qadr of Allah subhanahu wa ta'ala. Sometimes we get confused about this, because some people say the disease was from Allah subhanahu wa ta'ala. So if you try to treat it like you're opposing Allah's wish, no. Your treatment and the disease are all part of Allah's qadr. Now, we cannot tell what will happen. Our duty is to do what we can to preserve health. In the end, it is Allah who will decide about life. And we shouldn't also go into the mistaken thinking that when disease occurs, it is punishment for sins. Sometimes yes, sometimes no. So we don't know. So we shouldn't go into that debate. Also, sometimes disease can be a way for Allah to forgive sins. When Allah wants to forgive you, he gives you a disease, and from that suffering and from your dua for cure, Allah can forgive your sins. Now, talking more about the centrality of life, a human being has a right to life, and also he has got a right to what keeps life in the best condition: nutrition, hydration, medical treatment, freedom from pain and suffering. So sometimes we have got terminal patients. Don't assume that because they are going to die, well, why give them nutrition? Why hydrate them? Why treat their pain? No, you have to treat their pain. You have to make sure that they are not suffering, although you know they are going to die soon, because they have a right to these things. The person or the patient has a right to informed autonomous consent. You don't do anything to the patient until you have explained everything to them and they agree. That is called informed consent. Consent means agreement after being explained everything. Now, this autonomous consent is the main tool by which the patient can protect his life. Because, you know, in a medical situation, the person who cares most about life is the patient himself. The doctor may have other reasons. Maybe the doctor may want to do an operation because there is money involved. Other things may be involved, but the patient cannot put his life in danger. That's why we say the patient must agree to your procedures. You do not do anything without the patient agreement. But the patient doesn't know medicine, so you need to inform them. You need to explain to them in simple language what is the disease and what's the treatment, what are the benefits, what are the harms of that treatment, so that they can make a decision. Generally, the decision of a competent patient, competent means a patient who understands. If the competent patient makes a decision, that decision is predominant, even if illogical and harmful. Sometimes we go through the pain of accepting a wrong decision by the patient, but that's their right. We cannot violate their right. Sayyidina Abu Bakr, in his terminal illness, refused treatment. The Prophet ﷺ also, in his terminal treatment, refused to give him certain treatments. So the patient has the right to decide. And as doctors, it's our ethical duty to remember this and not be paternalistic. Paternalistic means we decide for them as if they do not understand. But sometimes the patient is not competent. The patient cannot decide, either because they are drowsy or they're intellectually deficient. So we need to use proxy decision makers. Proxy means one who decides on behalf of the patient. Generally, these are members of the family or the parents will decide if the patient cannot decide. But again, as I said, bioethics is conflicts. Sometimes the proxy decision maker may not appear to make decisions in the best interest of the patient, like a child. Like if the parents refuse to transfuse blood into a child whose hemoglobin is very low and may die, we may take away that autonomy from the parents. We can go to a court of law and the judge can give the hospital the right to make the decision and take it away from the parents because they are not acting in the best interest of the patient. We've talked about responsibilities to your own life as a patient, but also as a patient, you have responsibility to others. For example, organ donation. When you are in terminal illness or not even in terminal illness, and you donate an organ, that is fulfilling a responsibility to others in society. Also agreeing to be part of a clinical trial, clinical research. You are fulfilling a responsibility to society because this research will lead to information that we may help other people. Again, as part of the conflicts in bioethics, you may have physician autonomy against patient autonomy. See, the patient wants an operation, that's his decision, but the physician thinks it's not the right operation. So the physician also has got autonomy. He cannot be forced into something that he does not want to do. As I said, fiqh rulings can be used to solve many problems, but there are things that can be beyond the fiqh. For example, the moment of death. How do we know that somebody has died and we need to stop artificial life support? This is an ethical issue, and it was discussed by ethicists, and a solution was to develop the concept of brain death. That if the brain is dead, somebody is dead. Maybe other organs may be survive, but once the brain is dead, we consider somebody is dead. Some of these decisions, based on high technology, have caused a pushback. You know, some people are pushing back against biotechnology because they think it is making a human body like a machine. Now, when we are in terminal life, when somebody is near death, there are ethical issues that arise. One of them is who owns life? Who should decide about life? Because in terminal illness, we reach a stage when we need to stop life support. But who makes this decision? Whose life is it? Is it the patient? Is it the family? We need to know that life belongs to Allah subhanahu wa ta'ala. The patient cannot say, terminate, it's my life, it's my decision. No. Life belongs to Allah subhanahu wa ta'ala, and decisions about terminating life must be made according to the laws of Allah subhanahu wa ta'ala. So if according to the laws, according to the qawaid and maqasid, we realize that there is no point in continuing, we can stop artificial life support. But the patient cannot tell us to stop because he says it is his life. No, life belongs to Allah subhanahu wa ta'ala. Now, also, you can have another conflict. You see, some diseases can be prevented or treated prenatally while in the uterus. Yesterday, we were dealing with an ethical issue of using a balloon to treat stenosis in the heart when the baby is still in the uterus. So, treatment of disease prenatally and postnatally are part of Allah's qadar, not against it. Some people do not want to treat conditions because they say you are opposing Allah. No, the disease and what you do are part of Allah's qadar. You cannot treat except with Allah's permission. So we as human beings, we use all the available human knowledge to try to preserve health as much as possible. But we know in the end, mashi'atullah, it is Allah's will that will be, will be done. Now, when dealing with a terminal patient who is near death, we need to look at the quality and not quantity of life. So when somebody is in terminal illness, we want to make the quality of his life as best as we can. Because as I told you, the quantity is not in our authority. The quantity of life, how long somebody will live, belongs to Allah subhanahu wa ta'ala. So our aim is the quality. We want to make sure that they can make wudu, that they can make salah, they do their ibadah, they are cleaned, hygiene, we treat their pain, we communicate with them. We need to emphasize quality in the ICU. And this is the basis of Islamic bioethics, quality and not quantity of life. But we can reach a stage of futility, it's called futility, when we realize that any further intervention will not help. Then we can stop the intervention because it's no longer necessary. Now, as we come to the end, I want again to talk about management of pain. We never stop treating pain of a terminal patient because this is part of the quality of life. We need to make sure people do not die in suffering and in pain. But as I said, bioethics is balance. We must establish a balance between pain control and social functioning. When somebody is in the terminal stages, they need to be able to talk with their family, communicate with their family, socialize with them. Now, the pain control, as you know, analgesics are usually also sedative. You may knock them out so that they cannot talk with the family. So we need to establish a balance in terms of sedative analgesics, not to have 100% pain control. So we leave them with the ability to still talk with their family. In terminal illness, euthanasia is haram. Life is in the hands of Allah, yuhyi wa yumit. We as doctors cannot take away life. Also, we cannot help patients to commit suicide because the patient does not own his life. It's the life of Allah subhanahu wa ta'ala, and hifdh al-nafs, we cannot help them. Abortion destroys life. It's prohibited except when there is a conflict. Again, bioethics always conflicts. When the maternal life is at risk and the fetal life, the embryo life is at risk. Now, it's a conflict. If you save the embryo, the mother will die. If you save the mother, the embryo may die. So this is a conflict that the ulama say they can allow abortion only if the life of the mother is at risk. But there is something we need to understand. We are not comparing the life of the mother to the life of the embryo because every life is equal to every other life. As Quran says, وَمَنْ قَتَلَ نَفْسًا كَنَّمَا قَتَلَ النَّاسَ جَمِيعًا. If you kill one person, it's like you have killed everybody. So the mother's life and the life of the baby are of the same value. The difference is, if we do not make the abortion, the mother will die. And if the mother dies, the baby also will die. So we are losing two people. So abortion here is carried out for a simple mathematical reason that you lose one person instead of losing two people. Not because the life of the mother is more important than the life of the baby. And this is a basic Islamic ethical assertion. Finally, again, as we talk about quality of life, low quality of life in congenital anomalies, because many children are born with anomalies and their life is of very low quality. They cannot live a normal life. That does not justify abortion. It does not justify withdrawal of life support. As long as there is life, we need to protect life because that's the most important the principle, hifdh al-nafs. So low quality is no reason for destroying life. We need to maintain life as much as possible. Thank you very much. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Prof. Omar, for your excellent and interesting talk. Now perhaps we can make a start to discussion. The first, maybe we have one or two questions from the chat box. Need to inform that the question can be written in the chat box or also can raise hand in the Twitter Zoom. The first question from Prof. Hendro. Prof. Hendro, you wanna ask to direct to Prof. Omar, or may I read in the chat box, Prof?
Yeah, you can read for me from the chat box.
Okay.
So that I can focus on answering the question.
Okay.
Yes.
Yeah. The first question from Prof. Hendro, what is the maximum limit for applying the principle of autonomy in bioethics in a patient with a disease that is difficult to treat? Please, maybe we direct to answer, Prof.
Okay, what's the maximum time?
Maximum limit for applying the principle of autonomy in bioethics.
Yes, the principle of autonomy has no limit. The patient has got 100% right to autonomy, unless they are incompetent. If we suspect that they do not understand, their intellect is deficient, in which case they lose that right and their family can make a decision for them. But also, if we feel that the family are not making decisions in the best interest of the patient, we can take away that right and the court can make the decision. The judge can, the qadi can make the decision.
Okay. Prof. Hendro, is it enough or you can confirm? Okay, thank you. The second question from Dr. Ramirez is about what potential harm are ethically acceptable in the generation of health science knowledge, especially in the context of the pandemics, and what corresponding safeguard can be put in place. This, Prof. Omar.
Yes. There is no simple answer to that. It's always a balance. We need to balance al-maslaha, the benefit, with al-mafsada, the harm. And there are detailed rules in the fiqh. I didn't go through them on how to make the balance. If the benefit is more, then we go ahead. If the harm is more, we don't do it. If the two are equal, they are of equal worth, then we are conservative. We don't go ahead. So it's always based on the balance between the two.
Okay, thank you, Prof. Omar. Dr. Ramirez, you have enough for the answer from Prof. Kasule, or you can confirm about something like that? Dr. Ramirez, okay. Thank you. And the third question from Dewi Rati. Question from Prof. Omar. Please explain what is meant by balance between responsibility of patient and responsibility of science in research. How do we set a priority? Please, Prof.
Yes. The patient has got a responsibility to contribute to the growth of science by volunteering. Please listen carefully. By volunteering to be part of an experiment or a research. We cannot force patients to be in research, but it is part of their responsibility to society to volunteer to be in the research, because the knowledge we'll get from research will benefit everybody in society. But then they have got a responsibility to their life, because when they go into research, they are taking a risk. They could harm their life. So we need a balance between the two. Bioethics is very difficult because it's always difficult to find the balance.
Dewi Rati, have you satisfied or something like one confirm or can answer or can confirm something like that? No. Okay. Thank you, Prof. Because we have two moderators in this session, me and Dr. Eka, and the next termin or the second part question will be moderated by Dr. Eka. Please, Dr. Eka.
Okay, thank you, Dr. Mia. Prof, allow me to lead the second session of the discussion. The first question is from Dr. Mira. It's about euthanasia. If the family insists want to do the euthanasia, what should we do as the doctor?
Yes, that's when, or first of all, we need to understand the meaning of the word euthanasia. Because from many times I've been in Indonesia, I think it's got a slightly different meaning. Let me make sure what we mean by euthanasia. Euthanasia means a patient has a disease and is suffering. So we say, let us kill the patient so that he does not continue to suffer. It's called qatl al-rahma, mass killing. This is what we mean by euthanasia. This is haram. But there is what we call refuse of treatment. A patient can refuse treatment. They have a right to refuse treatment. This is their right. They can refuse. Sayyidina Abu Bakr refused treatment in terminal illness. There's no problem with that. The only issue is if he says, please don't treat me because I want to die, then we're in trouble. We are not going to listen to them. But if they just want to refuse treatment, it's their right. The only issue is if they relate it to death, because life and death are in the hands of Allah subhanahu wa ta'ala.
Okay, Dr. Mira, is it enough? Okay. The other question is from Dr. Anna Surgeon Peterini. She asked about, would you like to share your opinion about cardiac arrest in critical ill caused by COVID-19? Should we do CPR?
Yeah. Well, hifdh al-nafs means you preserve life. So when there is cardiac arrest, you have to resuscitate. We don't have a question about that. But there are some conditions, chronic conditions in the ICU, maybe on the ward, when we write what we call DNR, do not resuscitate. There are certain situations when the patient is so sick that the 3 doctors write that if this person has got a cardiac arrest, do not resuscitate. This is called DNR. DNR is accepted. So if there is a DNR order and there is a cardiac arrest, you do not resuscitate. But if there's no DNR order, you must always resuscitate. And you do what you can. You can give oxygen, you can do chest compressions, what you can do. Because preserving life, hifdh al-nafs, is the most important thing in our profession.
Okay. Dr. Anna, is it enough? I think it's enough. We still have question from Prof. Eva. Prof. Eva has raised her hand. Please, Prof. Eva, if you want to ask directly to Prof. Omar.
Okay, thank you. Assalamualaikum, Prof. Omar.
Waalaikumsalam.
We are very happy to see you and to hear your voice again. After so long time, I didn't see you and not hear your voice. Yeah.
Alhamdulillah.
You give the speak in Unisba. Yeah. My question is for the terminal patient. If the family has no more money for cure the disease, so what we have to do and who is the responsibility for him?
Well, that's a very difficult question because it is a judgment against the society, against the community. How come we cannot help the poor people? Where is our zakah? Where is our sadaqah? Where? And we've got many rich people. So really, the ethics of this is bigger than the ICU. The whole society, the government, we must be able to take care of all our citizens. But for the hospital management, you cannot just throw out somebody from the ICU. You may need to give a lower level of care, maybe. Transfer from ICU to a normal ward. You just cannot tell them, walk out of it, you have no money. really it's not ethical. But also I understand you cannot continue if there are no resources, but try to give them the care that they can afford, and you must have something that they can afford. Yeah, maybe they go to the main ward, maybe transfer to a lower level hospital, a secondary level hospital. But we just cannot kick them out. We need to try to do something to preserve life.
Professor Omar, but usually the hospital send home the patient if there is a terminal condition.
If the patient is in terminal condition, as in ICU, okay, then you need to make a decision about DNR. You make a do not resuscitate decision, because ICU is basically about resuscitating life support. So if you have got such a decision, then you can move them to a normal ward, which is less expensive. Or if you can check, maybe already they're brain dead. If they're brain dead, then you remove life support. There's no reason to continue in the ICU. So you see, maqasid al-sharia, there is hifd al-nafs, life, and hifd al-mal, and resources. We need a balance. We may reach a stage when consideration of resources becomes predominant because there is no more life. Then in which case we can remove them from the ICU.
Thank you, Mr. Omar.
Is it enough, Prof?
Yes.
Okay, thank you. Okay, this is the last question, Prof, from Dr. Dadang Rukanta.
Yes.
He asks about what is your
He's
suggestion?
my friend. I know him very well. Huh?
Yeah. Maybe Dr. Dadang ask direct to Prof. Omar. Dr. Dadang. Ada ya. Dibaca.
Okay.
Tapi boleh di-unmute.
Oh ya, mangga.
Mangga, Dok.
Assalamualaikum.
Waalaikumsalam. Alhamdulillah.
It's great to see you again.
Insyaallah, insyaallah.
Yeah.
Naam.
Prof, alhamdulillah nih. Thank you for your great presentation. It's for me surprising for our about the Qawaid Syariah, Maqasid Syariah. Alhamdulillah, in UNISBA we have the kuliah about the implementation or introduction of Qawaid Maqasid Syariah.
Yes.
In your suggestion, what your suggestion to implementation this Qawaid Maqasid Syariah for medical students in preclinic or the hospital?
Yeah, I think we need to keep teaching from the beginning.
Yes.
Throughout. We phase out the teaching. At the beginning, we may teach them more theoretical things about maqasid and qawaid, but once they go into the clinical years, we actually try to show how we apply them to real cases. Implement on real cases. Yes.
Okay. I see. This is the answer. Maybe Dr. Mia as the education, medical education. Syukran, Prof. Omar Kasule.
Yes.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
That was the last question for the second session of discussion. I will return this to Dr. Mia Kusmiati. Thank you, Prof.
Okay. Allah jazaik khair.
Thank you, Prof. Omar. Thank you, Dr. Eka, and thank you for the all asking for the Prof. Omar. Maybe we have the last session. Prof, allow me to summarize the discussion, Prof.
Yes.
Okay. From all discussion previously, from about seven asking question to Prof. Omar Kasule, we can summarize that Actually, we have two rules of why to guide our life or our conducting in medical professionalism. The first, we have objective of the law, and we call them the Maqasid as-Syariah. And the last one, we have the principle of law, and we call them the Qaidat as-Syariah. For the Maqasid as-Syariah, we have 5 things which are protection, preservation, and promotion of the one is morality or hifduddin, and then life and health or hifdun nafs, the third progeny or hifdun an-nasl, the fourth intellect, hifdun al-aql, and the last hifdul al-mal, or we preserve and protect the property. And the last principle, or the other principle for our to guide life day to day in our medical professionalism, we have the principle of the law that operationalize the Maqasid. The first is principle of intention, Qaidat al-Qasd, which emphasize that all procedures are judged by the underlying intention, or we call them the niyat. And the second principle of certainty, or we call them the Qaidat al-Yakin, emphasize that all action must be based on certain evidence. And the third principle of harm, or Qaidat ad-Darar, emphasize that benefit must be maximized and the harm must be minimized. And the fourth principle of difficulty, or we call them the Qaidat al-Masakot, that emphasize and that confirm that exception to existing regulation can be made in cases of necessity or darurat. And the last principle is about principle of precedent, or we call them the Qaidat al-Urf, which emphasize that generally accepted professional procedure must be followed. And maybe for the session is enough because the time is up. Thank you again, Prof. Omar Hasan Kasule, for your presentation and your contribution to share your knowledge. And this is our very valuable for us, for UNISBA, especially in integration Islamic to medical curriculum. Thank you very much. Syukron, jazakallah, khairan katsir. Billahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Jazakumullah khair. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Mia Kusmiati and Dr. Eka Nurhayati as the moderator, and Professor Dr. Omar Hasan Kasule from King Fahd University, Saudi Arabia, as the plenary speaker. And also, we learned a lot from the topic and discussion. Thank you very much. Jazakumullah khair. And back to Ms. Santi.
Thank you. So continue as the recognition and appreciation from the BICMHS committee. We would like to give a token of appreciations to our plenary speaker and also the moderators. So please kindly welcome Dr. Mirasari Putri, Dr. Ph.D., to give a token of appreciation to Professor Dr. Omar Hasan Kasule from King Fahd University, Saudi Arabia as the plenary speaker. Please welcome Dr. Mirasari.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much. Thank you very much, Professor Omar Hasan Kasule, for your very great speech. And then I'm really sure that many audience here got many previous knowledge regarding the Islamic bioethic. And then yes, after the pandemic is over, you can come to Indonesia and visit our university. Okay. And then once again, audience, please give a very big applause to Professor Omar Hasan Kasule. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much once again to Professor Dr. Omar Hasan Kasule. And then next, still in the token of appreciation moment, once again to Dr. Mira Sari Putri to give a token of appreciations to Dr. Mia Kusmiati and also Dr. Eka Nurhayati as the moderator of the second plenary speaker session at the BICMHS 2021.
Okay, thank you very much for Dr. Mia Kusmiati dan Dr. Eka Nurhayati for your contribution as the moderators for this conference. We really appreciate it. Thank you.
Okay, welcome, Dr. Mira.
Okay, thank you once again, Dr. Mira Sari Putri, Dr. Mia Kusmiati, and Dr. Eka Nurhayati.
Well, ladies and gentlemen, moving on to the online presentation session. Now we will have the second session that will consist of 6 presenters from public health track. In the session, we will have Professor Dr. Ifa B. Akbar, Dr. IF, and Dr. Cheryl Ramirez as the session chair. And before the chairing the session, we would like to read her profile. Professor Dr. Ifa B. Akbar, IF, is a psychology professor, physiology professor at the Universitas Islam Bandung, Indonesia, from Faculty of Medicine. And also she was born in Ciamis and spent his youth there. She completed her undergraduate to postgraduate education at the Faculty of Medicine, Universitas Padjadjaran, Bandung, Indonesia. She served as Dean of the Faculty of Medicine at the Universitas Islam Bandung for 2 terms, from 2012 until 2016, and from 2016 to 2020. She is currently supervising students attending seminars and workshops, as well as actively participating in research. And the next.
Okay, continuing to our second session chair of the second session of the online presentation session, please welcome Dr. Cheryl Ramirez. So Dr. Cheryl Ramirez is a registered nurse and a licensed professional teacher from the Philippines with advanced degree in nursing from the University of the Philippines and a Ph.D. in educational policy and administration. Her career evolved from clinical practice as an ICU nurse with USRN recognition, as a magnet nurse by the American Nurses Credentialing Center, to teaching practice as nursing faculty and professor at the Graduate School of Education at Universidad de Manila, where she is currently the research director. Her research areas of interest are innovative pedagogy, resiliency, and transformation across health and education to respond to global pandemic challenges. As a researcher, a research collaborator, and a reviewer of the International Journal of African Nursing Sciences, published by Elsevier with the previous works on emotional quotient and leadership, organizational climate, organizational learning, and research efficacy of teachers. Back to Mr. Yusuf.
Okay, Professor Dr. Ifa B. Akbar, Dr. IF, and Dr. Cheryl Ramirez, thank you for being with us today. And from now onwards, I will pass the session to be led by both of you. And now this time is yours to chair the session. Please welcome Professor Dr. Ifa B. Akbar, Dr. IF, and Dr. Cheryl Ramirez.
Thank you, Pak Yusuf. First, I want to make a correction. I was born in Jakarta, not in Ciamis.
Thank you.
I spent my youth.
Apologies for that.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, all. Welcome to this session. It's an honor for me to be a moderator. So I would like to thank to the Dean, Professor Dr. Nanan Sekarwana, to Dr. Mia Kusmiati, Ph.D., and to Dr. Santi as a as a committee. As a moderator for this session, I with Dr. Cheryl, with Dr. Ramirez. So maybe there are 6 presenter. Frederick T. De Vera, title paper physician satisfaction with the service quality of a clinical laboratory in Kalapan City, Oriental Mindoro. And next, second presenter, Septa Katmawanti, the relationship between mother's education level, mother's knowledge, and breastfeeding status with toddler motor skill and nutrition status in Diwe Subdistrict Jombang Regency, East Java, Indonesia. And third presenter is Eka Nurhayati, factor influence healthcare service delivery during COVID-19 pandemic, a case study in Cicalengka, Indonesia. The other presenter should be informed by our partner, Dr. Ramirez, please.
Okay, so good afternoon, everybody. Greetings from the Philippines. I'm so glad to be part of this learning forum. So I will be taking or facilitating the last 3 presenters. So I will be presenting Noreen Pansha with the title, The Correlation Between Anxiety and Insomnia Levels to Families of Health Workers During the COVID-19 Pandemic. And then we have Dr. Aldo Dimitri Daiva presenting his papers titled Relationship of Access to Clean Water with Prevalence of Stunting in Puskesmas Sikakenka in 2020. And the last presenter would be Fahar Awalia Yulianto with the title Relationship Between Dietary Approach to Stop Hypertension or DASH to Knowledge and Hypertension. So that will be the last 3 for me. So it's gonna be Dr. Liva doing the first 3 and I will facilitate the last 3. Thank you.
Maybe we have to give the guideline for the presenter. It is share, yeah. I think this is a guideline for presenter. You have a time about 5 to 7 minutes for presentation and 3 to 5 minutes for question and answer. And then presentation directly followed by the discussion. So the questionnaire can give after the presenter present the paper. Now, I would like to invite Mr. Sherik T. De Vera to present his paper. Please, the time is yours.
Good day. Can everybody see my screen?
Not yet, sir. Yeah, you're good. You just have to slide.
Can everybody see the screen?
Yes, yes.
Yes, it is on.
May I start?
Dr. Liva, is he?
Yeah.
Are we good? Okay. So again, we would like to welcome Dr. Sherik De Vera for the first presentation as introduced by Dr. Liva earlier. So go ahead, sir. Thank you.
Thank you. So good day, everyone. I am Sherik De Vera, and I am here to present to you our study entitled Physician Satisfaction with the Service Quality of a Clinical Laboratory in Kalapan City, Oriental Mindoro, Philippines. So clinical laboratories are an essential part of any healthcare institution. In fact, laboratory results account for more than 70% of clinical decisions. They are the primary source of information for clinical diagnosis. As a result, they must be well structured and effectively functioning. Although clinical laboratories serve a variety of customers, physicians remain to be their principal clients. The clinical laboratory's mission, therefore, is to deliver high-quality diagnostic testing, as physicians rely on the findings of laboratory tests to formulate accurate diagnosis and treatment plans for their patients. Satisfaction is a crucial parameter for analyzing and evaluating the quality of service. Thus, assessing physician satisfaction, who often engage with the laboratory, is critical and can aid in determining which parts of the laboratory need improvement. This is to guarantee that expected outcomes are achieved. Our study is primarily based from three theories: the ServQual theory that assesses service quality through the consumer's perspective, and the end result theory, which demonstrates how service is distributed. These theories then bridge to the Don-obedience theory, a tripartite framework that structure, process, and outcomes that aims to assess the health service quality through satisfaction. It is through these theories that our team was able to identify factors involved in the evaluation of the laboratory service that would help us assess physician satisfaction. As recognizing these issues will assist the laboratory in providing high-quality services. In line with this, the purpose of the study is to assess physician satisfaction with the service quality of a clinical laboratory in Calapan City, Oriental Mindoro, Philippines. This is done to evaluate the lab's service quality and identify areas that require quality improvement measures. This is also to correlate the factors and determine the impact of laboratory service on physician satisfaction. We have employed a mixed method approach, specifically a convergent research design, in order to formulate a conclusion through simultaneously collecting and analyzing quantitative and qualitative data. So here, this is a flowchart showing our progress from our ethics approval to the data collection. Following approval from the ethics committee, our team submitted a letter of consent to the hospital administration in order to get authorization to perform the study in the chosen hospital. We then conducted a census on the study site, which is in a clinical laboratory located in Calapan City, Oriental Mindoro, Philippines. After which, we proceeded by selecting the potential respondents for the study. The respondents are qualified to partake in the study if they are licensed physicians who work in the hospital where the clinical laboratory is also located, whereas those who did not meet the qualifications are then dismissed. The eligible respondents were then introduced to the study, and the consent form and survey questionnaires were also disseminated. After agreeing to the consent form, the respondents now answered the survey. A sample size of 42 respondents were gathered. The respondents who agreed to participate in the study proceeded in answering the survey questionnaire, which consists of a 5-point Likert scale and open-ended questions. The data collection was conducted from April to May of 2021. Following data collection, we proceeded to tally and perform our statistical analysis. Quantitative data is analyzed using IBM SPSS 22, where tests such as the descriptive statistics, Kendall-Tau correlation, and multiple linear regressions were performed. On the other hand, qualitative data such as open-ended questions were processed using the MaxQDA analysis to generate word clouds and frequency tables to identify recurring themes. The findings were then interpreted and analyzed in order to draw conclusions and provide recommendations of the study. Moving on to the findings and discussion. For quantitative data, we first conducted descriptive statistics to know if the physicians are satisfied with the quality of service of a clinical laboratory. So here, Table 1 presents the overall satisfaction of the 42 physicians with the clinical laboratory service, showing that the respondents strongly agreed that the clinical laboratory is accessible, provides efficient and effective laboratory reports, and provision of services, as their mean is greater than 4.21. On the other hand, the respondents agreed that the laboratory provides adequate turnaround time, and that they are satisfied with its laboratory information system, as the mean of their scores ranges from 3.41 to 4.2. All in all, the overall mean score for the physician satisfaction is 3.9762, which indicates high level from 1 to 5 satisfaction score. Here, Table 2 depicts the correlation between the factors and physician's overall satisfaction using Kendall-Tau correlation. The Kendall-Tau correlation is done to determine the impact of laboratory service capabilities on the overall satisfaction of physicians. The findings revealed that all factors had a high positive correlation with physician satisfaction and are statistically significant since their p-value is less than 0.05 and their Kendall-Tau is more than 0.35. Thus, we can conclude that there is a significant association between the factors and the physician satisfaction, and all the factors are statistically significant. Since Kendall-Tau correlation only determines the association of the factors towards the overall physician satisfaction, multiple linear regression was also performed to individually analyze the impact of each service quality towards the overall physician satisfaction. Based on the results, laboratory accessibility and provision of services do not contribute significantly to the overall satisfaction score, as their p-value is greater than 0.05. Nonetheless, even if these two factors are the least of the physician's concern, they should still be focused on, as they will affect the results once all factors are taken as a whole. Whereas the other factors contribute significantly to the overall satisfaction score, as their p-value is less than 0.05. Moving on to the qualitative data, this is the word cloud for the recommendations from the respondents. Word clouds were generated using MaxQDA in order to easily visualize and identify the suggestions of the physicians. Most recommendations targeted the provision of services with 26.18%. This is the word cloud of the list of negative regard of the respondents towards the clinical laboratory, where almost half of the respondents do not have a negative outlook for the laboratory. However, 23.82% are not pleased with the turnaround time of the laboratory. Going on to the conclusion and further research. Based on the Kendall-Tau correlation, all the factors assessed have a significant correlation with physician satisfaction. But in summary, the physicians are satisfied with the laboratory services, however, not completely satisfied, as their mean overall satisfaction level is only under the agree category and not the strongly agree. This implies that there are still areas that need improvement. The physicians have significant negative regards for the turnaround time of the laboratory. Delay in reporting test findings can cause delay in patient care, assessment, management, and release. Thus, physicians recommend that the service provision be improved. The laboratory administration must reassess the effectiveness and efficiency of its laboratory services. The physicians recommend that the laboratory's workforce be expanded, staff competency be enhanced, laboratory sections be upgraded, and additional apparatuses be procured. In doing so, the laboratory service quality will be improved, especially its turnaround time. These findings can be optimized as a baseline for any initiative geared at improving the quality of laboratory services. However, note that this study was limited to respondents from a single hospital and its laboratory. To be more comprehensive, future studies could include hospitals and clinical labs from every region of a country to have a larger sample size, including physicians and laboratory in each province, because this will help better understand the situation and conditions that transpire at the regional and country levels, making collaborative development possible. Thank you.
Okay, Mr. Cedric, it's a very great presentation, and it's us as the physician, because we always send. And I think this laboratory is only one in that hospital, yeah. Same in the hospital, yeah. Okay, now we open for the question, and there are some question that deliver for you. Maybe
Doc,
yeah.
do you want me to read it for you?
Yeah.
Yes. So we do have one question in the chat box. It says from Dr. Hendro Sojono, and it says, why or what is the causes of the provision of service is not significant? Great presentation, and thank you. So what are the causes of the provision of service? Maybe we wanted to, if he can paraphrase that. Okay. Did you get that, Dr. De Vera?
I'm a student pa lang.
Okay. Sorry.
Before anything else, I would like to thank the BICMHS for giving us the opportunity to present our paper. So to answer the question, a lot of physicians complained about lack of facilities and equipment that falls under the provision of services. And we categorize these answers as the provision of services.
Dr. Hendro, did that satisfy you, the answer? So I hope so. Okay, thank you, sir. I guess if there's none, I would want to push a question, one question for you, Sir Cedric. Yeah, very interested with the max QDA because we normally just use the IBMS, the SPSS, IBM SPSS. So could you share to us briefly how efficient or how easy it is for use for max QDA for us, for those people who are interested to do qualitative studies, like for example, in comparison with NVivo or Atlas TI. So if you could just share your experience so we could learn from it.
So we were able to generate our word clouds by open-ended questions. So there were no specific answers, but we categorized each of their comments into one word cloud. It was quite fun categorizing them, and it's very simple to do.
Yeah, well, I must agree with this next question from Ma'am Santi, because she was trying to emphasize, do you think the non-recommendation coming out from the word cloud can lead to ambiguous findings, since the respondent did not tell any recommendation towards the laboratory?
Oh, so for that question, thank you. That was a good question. We often encounter that question, but with the max QDA, the none. Oh wait, I'm trying to.
Yeah, because the max QDA, I'm not that familiar, but I know there is also that feature for organizing first. Then then it will also categorize, and then it will lead you to the managing of the code. So basically, so that's the question of what if the answer is none. So how would you address that? Because you cannot explore further. It would just, I can see what Ma'am Santi is saying. It would just stop there. Unlike when we are doing focus interviews and we are there and getting it manually, coding it manually or writing it manually, then you can explore, why did you say none? Or what was your reason behind it? But if you stop there, none, and it's computer-based, then it ends up there. So you would like to explore on that more.
None was considered because this means that they do not have any recommendations or complaints. So we categorize in that.
Thank you. So it's only one question more because we have limited time. I read for the question. Do you think the non-recommendation coming out from the word cloud will lead to ambiguous finding, since the respondent didn't tell any recommendation toward the laboratory?
We answered that earlier, but yeah, none doesn't lead to any ambiguous results because none was considered, because this means that they do not have any recommendation for complaints. And since quantitative data shows that decisions are satisfied.
Okay, how about Dr. Santi? Maybe we have to for the next presenter because it's a limited time. Thank you, Mr. Cherry. It's a very interesting and very important presentation. Okay. And now I would like to invite the next presenter. The next presenter is Septa Katmawanti from University Negeri Malang about the relationship between education level, mother's knowledge, and breastfeeding status with motor ability and nutritional status of toddler in Diwik District Jombang Regency. Okay, please, Miss Katmawati, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Thank you to Prof. Dr. Eva and Dr. Cheryl for the time. My name is Rahma Rizkia, the representation of the group who will present the result of our research. Have you seen my share screen?
Yes, ma'am, we do.
Okay. The title is the relationship between mother education level, mother knowledge, and breastfeeding status with total motor skill and nutrition status in the subdistrict Jombang Regency, East Java, Indonesia. The basic capital for the generation of quality human being begins when the baby is in the womb and is accompanied by the provision of breast milk from the early age, particularly exclusive breastfeeding. Breast milk contains all of the nutrients that baby requires, such as ARA and DHA fatty acid, with a function in the production of the nutrition that baby requires. The majority of the population in the world, Jombang Regency is educated with 5,759 people, or almost 10.30% having a higher education level. Furthermore, Diwik district is number 2 higher after Jombang Regency, Jombang district, who has the second highest number of highly educated people after Jombang district. The World Health Organization, or WHO, report that more than 200 million children under the age of 5 do not meet the potential for motor development. The majority of them are children from Asia and Africa. Furthermore, according to the result of a national data scale survey conducted by the Ministry of Health of Republic of Indonesia in 2014, around 30 until 18% of children under the age of 5 in Indonesia experience growth and development abnormalities. According to Jawa Persada Jombang, to Jawa Posradal Jombang, the result of the bulan timbang conducted in August 2019 revealed a stunting rate in Jombang of 12,013 dispersed throughout all of sub-district at the end of 2019. According to report, the Dewa sub-district has the greatest area of any of 19 sub-districts with 1,353 toddlers. Exclusive breastfeeding was 11.6%, the highest rate of exclusive breastfeeding in mother with degree of education. The category is never went to school was 12.4% in 2010. In 2013, exclusive breastfeeding was 30.2% according to Riskesdas in 2013. In 2018, the proportion of exclusive breastfeeding was 40.5%, dominant breastfeeding was 1.45%, and partial breastfeeding was 12%. Exclusive breastfeeding coverage in Jombang is 55%, predominant breastfeeding coverage is 9%, and partial breastfeeding coverage is 7.5%. Predominant breastfeeding in Jombang higher than East Java, is 9%. The predominant breastfeeding coverage rate in East Java is the greatest. Furthermore, according to the 2019 Jombang Health Profile, the exclusive breastfeeding coverage rate was 82.9%. The rate of exclusive breastfeeding coverage is 23% lower than in 2018 when it was 83.3%. Research update is in the dependent variable component of the study used two variable, namely nutritional status and motor skill. Breastfeeding is classified into three types according to Kemenkes RI 2014. Number one is exclusive breastfeeding, number two is dominant breastfeeding, and number three is partial breastfeeding. Predominant breastfeeding occurs when the baby is breastfed but has been given a small amount of water or water-based drink such as tea, as food, or pralactal drink before the milk comes out. The low level of maternal educating indicate that developing human resource through the degree of knowledge is critical for attempt to enhance children's nutritional condition. The mother lack of knowledge is the second reason. The main thing that is highly crucial for the formation of one action is knowledge or over behavior. There are numerous stages of knowledge, including knowing, comprehending, analyze, and applying. Research method, the research design used was a cross-sectional design. Before the researcher did an ethical test at Poltekkes Kemenkes Malang. The sample was selected through non-probability sampling in the form of purposive sampling. The population in this study include 9,264 infant age 0 until 4 years in the district emergency. Using the sample size calculating above, the number of participants to be analyzed was 189 infant age 0 until 4 years in the district emergency. The author then round up the sample to 200 mothers of infant and tutors who had accepted informed consent from the researcher. In this research, the inclusion is infant age 0 until 4 years with a normal body or not disabled, and mother with baby age 0 until 4 years in the district emergency. The exclusion is babies who were not tutored by their biological mother, baby who didn't receive breast milk from their biological mother, and toddler who live outside the sub-district human agency. Before being distributed to respondent, the instrument is evaluated for validity and reliability so that it can be used as a collecting data tool. The validity test of the questionnaire at the point of breastfeeding frequent revealed that it was valid because of the value of air count more than air table. Furthermore, the Cronbach alpha score of more than 0.70 indicate that the questionnaire reliability test on the variable of knowledge and breastfeeding status was reliable. The research applied the 2016 MGH Handbook and PMK number 2 of 2020 to assess toddler motor skill and nutritional status. The data analysis method used in this study were univariate analysis, bivariate analysis with the chi-square test, and multivariate analysis with regression logistic or binary test and ordinal regression. The result is based on the result of the table above, it is known that mothers with poor knowledge have children with poor motor skill in as many as 2 people or 1 person. Meanwhile, 16 people or 8% of women with moderate knowledge have children with poor total motor skill. 13 people or 6.5% are knowledge mother with children who have good motor skill. As many as 5 people or 2.5% have children with good motor skill despite their mother lack of knowledge. Children with good motor skill born to mother with moderate knowledge account for 136 kids or 68% of the total. Meanwhile, mothers with good knowledge have children with good motor skill as many as 28 people or 14%. In the percentage square test, the assigned value is 0.002 as the basis for decision making. This assigned value implies that HA is accepted. The level of knowledge mother has in maternal role attainment or MRA nursing theory is a factor that can affect and interact directly with individual. Furthermore, the mother level of knowledge is included in the microsystem layer, which is the major layer of element influencing the toddler's output, in this case, gross motor skill. The better the mother's knowledge or awareness, the better the development of the toddler. Number 2 is a relationship between mother educational level and toddler nutritional status in the district human agency. Based on the result of the table above, it is known that as many as 5 people or 2.5% of children under the age of 5 born to mother with low level of education had malnutrition status. In the percentage square test, the assigned value is 0.021. Based on the finding of assigned it is possible to deduct that alternative is approved. The level of education has a significant impact on a person's ability to understand and receive information. The level of education has a significant impact on a person's ability to understand and receive information. Increase human resource through increased knowledge in critical in the attempt to enhance children's nutritional status. Number 3 is relationship between mother's knowledge and toddler nutritional status in the district. According to the finding of statistic test, 126 women out of 200 total response, or 63% with knowledge about parenting children with high nutritional status. The p-value is 0.006. Choose HA alternative is accepted, indicating that there is a significant association
still 2 minutes
between mother education level and child motor skill di district Jombang. Number 4 is a relationship between breastfeeding status and toddler nutrition now in the district Jombang Regency. According to the finding of statistic of tests on the association between breastfeeding status and nutritional status of children under the age of 5, 80 of the 200 total response, or 40% of mothers with a high frequency of breastfeeding had children with good nutrition status, when the p-value is equal to 0.002, alternative is approved. As a result, it can be concluded that there is a significant correlation. Conclusion is based on the preceding reasoning, it is possible to conclude that one is there is a relationship between mother's knowledge and toddler motor skill. Number 2 is there is a relationship between the mother's educational level and the nutritional status of the toddler. Number 3 is there is a relationship between mother's knowledge and the nutritional status of the toddler in the district. Number 4 is there is a relationship between breastfeeding and nutritional status in toddler in the district Jombang Regency. Further research, number 1 is future researchers can look into aspects other than educational level, mother's knowledge, and breastfeeding status that can affect motor skill. Number 2, it is expected that additional study would be conducted in the integrated healthcare center in the work area of the Jukir Health Center, a total of 11 integrated healthcare center. Activity photo, and thank you.
Doc, you are muted.
Yeah, I know. So it's 2 questions. Yeah, from Professor Hendro. Please, breastfeeding is natural as in animal. So what is the exact reason the mother not give breastfeeding?
Miss Rama, did you get that? Do you want me to repeat the question for you?
Yeah.
Yeah. So we will go first to the first question. What kind of tool did you use to assess motor development in your study? And how did you assess nutritional status in your research project or subject? We cannot hear you, Rama. Can you unmute yourself, please?
Yeah. Yeah, please.
For the
so what kind of tool did you use to assess motor development in your study? And how did you assess nutritional status in your project?
I use MTH book 2016 and PMK number 2 2020.
Yeah, I think it was also Cronbach at 0.7, so I think that is very reliable because she tested that too, right? Yeah, I did see the Cronbach reliability test that you showed earlier. So, Prof. Liva, I guess in the interest of time, because we are way past the 15-minute mark, I guess we need to proceed to the next presenter. Thank you.
Yeah. Okay, this time I think it's very useful, yeah, especially for the mother. Yeah. Maybe please, I invite the third presenter, Miss Septa Eka Nurhayati.
Yes, thank you, Prof. Iva.
Dr. Eka is from Universitas Islam Bandung, and her team is Puskesmas Cicalengka.
Yes, that's correct, Prof. I'm asking permission to share my screen. Can you see my share screen?
Okay.
Okay.
Continue.
Okay, first of all, thank you for this opportunity to the committee and Prof. Iva and Dr. Sherry Ramirez as moderator. Allow me to present my study. It's entitled Factors Influence Healthcare Service Delivery During COVID-19 Pandemic in 2020, a case study in Cicalengka, Indonesia. Okay. Since the beginning of the COVID-19 pandemic in Indonesia, we know that the government has enforced social restriction, or we call it PSBB. And this enactment caused restriction on almost all activities in the community, including healthcare services. Primary healthcare center, or we know it as Puskesmas, which played role as the front line in healthcare delivery, has been doubling the duty since then. Currently, COVID-19 is the priority, but Puskesmas also responsible for delivering high-quality routine healthcare for the community. And since the enactment in 2020, Puskesmas Cicalengka, one of Puskesmas in Kabupaten Bandung in West Java, Indonesia, has been facing numerous problems which led to the failure of achieving the target of healthcare programs. As we can see on the screen, the healthcare output in 2020, based on the annual report, could not reach the target. We can see here many negative marks, which indicate that the programs cannot reach the target. This study was conducted based on logic model theory by W.K. Kellogg Foundation in 2004, which says that output determined by resources or inputs and activities. But in this study, our team only focused on input factors only. So the objective of this study was to identify the input factors which cause healthcare service delivery issues. The methodology of this study was the qualitative research using case study design, and we analyzed related documents such as annual reports, epidemiological data. We also observe the site, the Puskesmas, and we also conducted interview to the medical staff. And analysis were done using by gap analysis by comparing the input factors with the standard in the regulation of Ministry of Health number 43, 2019 about Puskesmas. And so the result, the Puskesmas was once closed in April 2020, and it was reopened in May 2020 with some new regulation from the Ministry of Health. The medical staff must use personal protective equipment, and they must conduct some new health protocols such as washing the hands, then using maskers and everything, and also they must arrange new healthcare service flow. And for the details of the input, from the workforce aspect or demand, we can see here that the quantity of the medical staff was exceeding the standard. But however, Puskesmas had experienced a crisis of medical staffs due to the infections of the COVID-19, which impacted to the medical staff. So they cannot give any services to the patient because they also have to fight the disease. And from the aspect of money, we can see that Puskesmas have other source of allocation, other source of budget, which is the Regional Public Service Agency budget, and the allocation, of course, we cannot tell that the COVID-19 will come in 2020, and so many budget was not related to was not planned to overcome COVID-19. And when COVID-19 hit Indonesia, the Puskesmas must allocate some allocate some funds to provide material and other things to follow the rule from the Ministry of Health. And the material, if we see here that the Puskesmas really need tools for antigen swabs and also disposable personal protective equipment and other materials for new health protocols such as sinks, disinfectant, and many others. And this one impacts to the budgeting. So it affects the other things. Machine, we can see that the machine, the ambulance, the Puskesmas have ambulance, 2 units of ambulance in good condition. So we can conclude that there were no resistance or obstacles in machines. And the method, we can see here on the screen that several methods has been changed. The healthcare delivery, healthcare was delivered with optimum disposable PPE. So the medical staff must use disposable PPE. All the methods implemented outdoor has been restricted. We cannot go to school, we cannot go to patient house, and also we cannot go to community directly. And the flow for patient services are modified. Patients now have to wash their hands first, and then they must queue before entering the Puskesmas. But however, the Puskesmas has not considered to use digital health technology to deliver healthcare. The minutes, the operating hours has been reduced since 2020, and more time have been allocated for COVID-19 related activities. So Puskesmas had a shorter time to deliver healthcare services. And information, as we can see, usually Puskesmas has some surveillance and also collected data every year. But however, since the COVID-19 pandemics, Puskesmas needs to collect new data, new information related to COVID-19, and also must collect the data for getting information on its impact on community. So the conclusion is that the input factors which affected healthcare delivery in Puskesmas Cicalengka in 2020 was man, money, material, methods needed, and information. While machine is not the one factors that affected healthcare. And the head of the Puskesmas must develop some strategies so we can achieve the target. And good governance is important in decision making in short time to rearrange resource. And we should consider digital technology such as telehealth as an option for healthcare delivery service. That's all. Thank you so much for all your attention.
Okay, thank you, Dr. Eka. Maybe first I want to ask you, because you your instrument is logic model framework, but you are only tick input factor. Why you didn't tick another factor?
Yes, due to shortage of time, we only have 4 weeks or 3 weeks to observe in the Puskesmas, and so we cannot observe the process. So we only see the input, because input we can assess from the annual report data.
Oh, okay, thank you. We continue with the other question from Santi Rahmawati. Good and real-time research, Bu Dr. Eka. Currently, how the Puskesmas handling all the challenge difficulties in healthcare delivery service?
Yes, in Puskesmas, I think it was challenging for all of us and also for the Puskesmas. And as we can see that Puskesmas had a lot of what we can say, is it failure? Yeah, it's failure to achieve the target. And however, we try to, as wise as we can, to step by step fixing this situation. So far, like I said before, that the priority is now COVID-19, but also we have responsibility to deliver healthcare. So the healthcare is still, the routine healthcare is still delivered for the community, but right now vaccination for COVID is the priority.
Okay, the other questions, is it satisfied, Bu Santi?
Doc, there is still one more question in the chat box.
Yeah, okay. Can you help to read it?
Sure. So Dr. Eka, how effort of PHE to provide healthcare service delivery during the COVID-19 pandemic if equipment is limited?
Yes. Okay. Yeah, the equipment is limited, but like I said before, the Puskesmas has some other source for budgeting, and they use it first for the limitation of equipment. So when they don't have the disposable PPE, they buy it first from the budget, but the other budget is what can I say? It was restrained from the other budget. So yeah, something's gotta give if it's given to the COVID, and the other one perhaps must a little bit. It's not forgotten, but what can I say? Not neglected. Apa istilah yang tepat ya?
Jadi the time is up ya.
Okay.
Secara di rest ya. Thank you, Dr. Eka.
Thank you, Prof. Iva.
We limited time, so the question can answer next. For the next presenter, I now, Dr. Ramirez, please serve the next presenter.
Yes, thank you, Dr. Liva. So we will have now the floor for Noreen Pansha with the title, The Correlation Between Anxiety and Insomnia Levels to Families of Healthcare Workers During the COVID-19. Sir.
Miss dari Pansah from Universitas Erlangga Health Office. Dari Miss dari Pansah.
Oh, it will be
with the.
It will be representing by Miss Lily Nabila. So admin, would you please
presented by Miss Lily? Okay, please.
Okay,
Miss
please.
Lily, it's your time.
Yeah, okay, already co-host, so you can unmute yourself. Okay, thank you.
Okay. Okay, good afternoon, ladies and gentlemen. I'd like to quickly introduce myself. I am Lili Nabila Amar. I will be the representative of the first author, Mr. Nur Irfan Shah, because he has to attend another event. And then I'd like to take this opportunity to talk about the correlation between anxiety and insomnia levels to families of health workers during COVID-19, an investigation in Indonesia. To begin, I'd like to share with you why we are interested in this topic. Several studies have investigated the prevalence of psychological problems in healthcare workers during the COVID-19 pandemic. Additionally, many studies have shown that it harms the psychological state of individuals. These studies investigated the psychological effects associated with the COVID-19 pandemic, focusing on symptoms such as anxiety, depression, stress, hopelessness, and fear associated with the disease. Not only health workers, but also the families of health workers experience psychological pressures. Based on our preliminary study, we did some interview to the family member, and then the researcher found that the family feels worried and anxious about their family members who works in a hospital to take care of the patients. And now this leads us to my next point, and then we have the hypothesis that state anxiety is positively related to the insomnia levels in the families of health workers during COVID-19. So our research aims to investigate the relationship between anxiety levels and insomnia in family members of health workers at Idaman Hospital Banjarbaru during the COVID-19 pandemic. Now I'd like to turn to the methodology. This research uses a cross-sectional approach using social media with the Google form, taking 125 correspondents as a sample. The research instrument used the DSS-21 and the Insomnia Severity Index. The data were analyzed using the SPSS program with the Spearman rank correlation test, working by testing the associative hypothesis of the two ordinal scale variables. Next, let's move on to the findings. A total of 70.4% of family members of health workers at Idaman Hospital Banjarbaru have a very severe level of anxiety. In addition, 46.4% of the families of health workers at Idaman Hospital Banjarbaru experience severe insomnia. The correlation for the state anxiety insomnia is 0.846 with a p-value under 0.05. This indicates that the two variables have a significant relationship with moderate correlation strengths. The direction of the positive correlation indicates that these two variables move in the same direction, meaning that the higher the anxiety, the higher insomnia is experienced. And then the findings is also related to the survey based in China, which stated that since the beginning of the COVID-19 outbreak, found that 53.8% of respondents had psychological effects as moderate or severe. 16.5% reported moderate to severe depressive symptoms, and 28.8% reported moderate to severe anxiety symptoms, and 8.1% reported moderate to severe stress levels. Psychological fear may be more intense now than it was 70 years ago during the SARS period, with increased air travel and increased global connectedness making the spread of pandemics much easier. In conclusion, nearly 80 people from family members of health workers experience high anxiety level. This also affects their sleep quality. Nearly 50% of them experience severe insomnia. Excessive concern about the health condition of the health workers who work to treat positive COVID-19 patients is increasing. Therefore, family members of health workers need to get great support from the various parties, including the government and all aspects of society, to reduce the psychological disorder. And then our research limitation due to the COVID-19 pandemics, the population was really limited. It is necessary to conduct further and comprehensive research on the psychological impact on the family members of health workers. And that brings us to the end. I'd like to thank you for your time and attention today.
Thank you, Ma'am Lily. That is a very informative and engaging, I would say very relevant study, because that is really applicable across the globe. Anxiety is expectedly be experienced by family members of healthcare workers because they are the ones being exposed. So in the meantime, since we don't have any questions at the moment, I will probably just add an input. I think this is a very good springboard for another study as well in the future, because this is quantitative, right? Yeah, I think because we are talking about the psychological aspect of the experience, I think it can also lead us to do further studies later on qualitatively. Yes, I think we can get a deep analysis and good output in terms of this. Yeah. So I guess, would anybody, if anybody would want to pose their questions, this is now the time for us. It's a very good study, very brief, but very concise, but very informative. So thank you for this information. We kind of know that there is anxiety, but this data, we need the data to support our assumptions. So, yeah.
A question maybe, Dr. Ramirez, I have a question, short question.
Sure, ma'am.
Yeah. Okay. I want to, why you take a correlation between anxiety and insomnia? Because with the SS21, we can also calculate about depression and stress scale.
Okay. Actually, we want to take the depression and also stress, but then as we found the first time we conduct the research, we haven't found that the family members had the depression. Probably they have like a little stressed, but it's because they feel anxious. So we just only talk about the anxiety and the insomnia because the stress level the stress level affected the stress level influence the anxiety. So if they feel if they feel stressed, they feel more anxious. That's why we just only talk about the anxiety level, but because when we also take the depression, they don't have any, the depression level is almost normal, ma'am.
Okay, thank you. Please, Dr. Ramirez, continue.
There is a question, actually, they are related. How were you able to control this? Because it's very interesting, you know. I don't know if ma'am or sir, but I would just address them from Yusriani and Yuk Adrian. They would like and they're interested to know how were you able to control the insomnia, the causes, how to exclude another cause of insomnia. So this is very sensitive because they may be suffering from insomnia due to other factors, not the being a COVID family. So what protection did you, or what protocol did you use to isolate and say that the insomnia is really due to the COVID exposure from being a family member?
Okay, so as I said that I use insomnia severity index, but then it's not recreate, we write it as it's all about the COVID, it's related to the COVID-19. So it's not the general questions when they fill the questionnaire. So we focusing on the questions about related to the COVID-19. So we just like it's not recreate. It's like we use the ISI, and then we put more information related to the COVID-19.
Right. So I think this is the one thing that we cannot control because this is them. So it will be safer if we can just put this under the limitation, because they are right. Ayuk and Yusrani have a point on this, because we have to really make sure that the insomnia is caused by that. But that's beyond your control, because this is a response survey. So yeah, but thank you, very informative.
Thank you.
With that, I guess if there are no more other questions, we can now proceed. Thank you, Ma'am Lily. So we will now proceed to the next presenter, from Dr. Alvi Dimitri Dalva and Dr. Eka and Dr. Yanti, but presenter is Dr. Aldo. The title is Relationship of Access to Clean Water with Prevalence of Stunting in Puskesmas Cicalengka in 2020. Sir.
Okay, I ask permission to share my PowerPoint. Okay, can you see my screen? Excuse me.
Yeah.
Okay, thank you, Dr. Cheryl and Prof. Iva. Okay, Assalamualaikum warahmatullahi wabarakatuh. Hamdan wa syukran lillah amma ba'd. Thank you for the opportunity so I can be a presenter in this conference. My name is Aldo Dimitri Deiva, and my topic is relationship of access to clean water with prevalence of stunting in Puskesmas Cicalengka in 2020. Wait a minute. Okay. Sorry. Okay. For introduction, stunting is chronic linear growth failure in children under 5 years, which is characterized by body height or length according to age below -2 standard deviation. Then for the epidemiology in worldwide, the prevalence of stunting in 2019 was 144 million or 21.3%. And in Indonesia, the prevalence of stunting, Indonesia was the third highest in the region of Southeast Asia. Then West Java province had prevalence of stunting as much as 31.2%, which is the 24th highest out of 33 provinces in Indonesia. Then Bandung Regency was ranked the fourth highest in terms of prevalence of stunting in West Java province, or 35.2%. District of Cicalengka was ranked as the sixth highest in terms of the prevalence of stunting in Bandung Regency. WHO target, which is to reduce stunting number to less than 20%. Bandung Regency strategic plan 2016 until 2021 target to reduce stunting prevalence less than 14%. Okay, for the stunting factors, there is two factors, direct and indirect. For the direct, the nutritional intake from food and supplement and infection can cause stunting. And for the indirect, the sanitation and hygiene, food endurance, and the parenting style can cause stunting. It can damage on the quality of human resources and decrease of health status. The coverage of access to clean water in public health center or Pusat Kesehatan Masyarakat, Puskesmas Cicalengka in 2020 was only 16.5%, while the target was 80%. This gap is thought to be related to the prevalence of stunting there. In research methodology, this study was an analytic research using cross-sectional design. That data was used in this research was data height per age in children under 5 years and data of access to clean water. Data were extracted from the annual report of Puskesmas Cicalengka in 2020. Children who has chronic infection such as tuberculosis and chronic non-infection disease were excluded. Okay, the annual report was 6,187 of data child. The data inclusion is 5,179 data. And then data exclusion is 108 data, which is 122 children who have history of tuberculosis, 14 children who have leukemia, and 872 children with no data of access to clean water. Data analysis using univariate analysis to describe the characteristic of subjects and chi-square test to measure the relationship between the two variables. Tools which was used to calculate the data was SPSS. Results of the study are presented in the form of table. And finding and discussion, this table shows that the age of 25 until 59 months is the most age, and the most gender is male, and stunting percentage is 33.2%. And children who has access to clean water is only 65.4%. Okay, this table shows that children who don't have access to clean water show a higher percentage of stunting. And then children who have access to clean water show a higher percentage of children who don't stunting. This the p-value. Okay, this is the mind map that poor sanitation can cause unclean water can cause infection can cause diarrhea, and then diarrhea can cause enteropathy, and then enteropathy can cause poor nutrition absorption, and then can cause stunting. Then Abate et al. On 2,733 children showed that there was a significant relationship between unclean water to the incidence of stunting. Unclean water can increase the risk of stunting 3.2 times. And then unclean water in rivers can harm human body and cause infections such as diarrhea. Study by Krishnana et al. Showed a significant relationship on unclean water and the incidence of diarrhea. Unclean water can increase the risk of diarrhea as much as 4.1 times. Repetitive diarrhea, especially in children, can cause enteropathy, which interferes the absorption of nutrients that is important for growth, and in the end lead to the incidence of stunting. And then for the conclusion, stunting are mostly happen in children who cannot access clean water. Clean water is needed to reduce the possibility of stunting. Improve collaboration between health environmental program and maternal and child health program in Puskesmas Cicalengka are needed to find the solution. Further research should be done by collecting primary data and classify the source of the clean water to achieve a comprehensive assessment. Okay, thank you for very nice attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Aldo. So that was again another topic that is very interesting with social impact, especially for this area in Indonesia, the Central Samba. Okay, so we have one question from Dr. Hendro Sujon. Access to clean water is not the same with unclean water. Can you explain more? What do you mean with access to clean water?
Okay, in this research, access to clean water is access to the child can get the clean water. In Indonesia, especially Cicalengka, the clean water from the tap of child house, such as water, is difficult to access because of what I say, jarak. Okay, distance. Yes, distance of the access to clean water is long. Yes, long distance of access to clean water. And then for the nutrients, distance too much long to be accessed for the child.
Yes, thank you. I would like to add on what Sir Aldo mentioned, addressing Dr. Hendro's question. Sir, according to the UNICEF, access to safe water is actually one of the main drivers of malnutrition, as he have explained earlier, related to the indirect effect to the nutritional status of the child. So, yeah, it's very important that we define our variables. I just have one question, Sir Aldo, in terms of the chi-square that you use. Do you have all categorical data that you processed, like the gender? Yes. Are they all categorical? Yeah. Okay. Including the height and all the other variables. Yeah, I'm just interested, what type of variables did you measure? Are they all categorical in nature? That's why you use chi-square?
Yes.
Yeah, okay.
Of course.
So I think we have two more and you have enough time. So we have time to address these questions. Is this cross-sectional or ecological study from Walia?
Cross-sectional. Yes, its study is cross-sectional.
So it's just one time.
Yes, one time, and the data is the secondary data, not primary data.
Oh, secondary data. Okay. And there's one more from Multi Dewantara. What are the parameters of clean water in Cicalengca, and how can people know that the water that they consume is clean or not?
For the clean water in Cicalengca, the water that can be drink to a child in people in Cicalengca. Then the water in Cicalengca is not the child cannot drink the water that the water is not be boiled for the child. And then the child must be long distance to access the clean water.
Okay. So the parameter is, I would like to address that question. The parameter is, you mean it has to be boiled, right?
Yes.
To become clean. Okay, yeah. That's the criteria. That's what she's looking or he's looking at. So it has
and
to
the
be
sanitation is bad, I think, in Cicalengca because there is not a city. Yes.
Okay. I think so. Ma'am Dewantara, are you satisfied with the parameter? So it should be boiled to become a clean, considered clean for the children to drink. Well, unfortunately, from other areas, not only in Indonesia, also I can say even in the Philippines, we do have areas that are inaccessible to clean water. And that's why here comes what public health is. And this is why we are doing this. So what can we do as people or professionals in the public health in terms of addressing this, especially for communities that don't have clean waters? So with that, Dr. Aldo, I guess everything is addressed and we can move on to the next, unless there is anybody raising their hands right now, but I think there's none. So the last but not the least, so thank you. So we are moving on to the last presenter. We have Sir Fahar Awalia Yulianto, the relationship between dietary approach to stop hypertension, or we call the DASH approach, to knowledge and hypertension. So, sir.
Okay, thank you very much, Ms. Sabriel. Can I send my presentation?
Yes, please, sir.
Okay. Wait a moment, please. There you are. Have you seen it?
Yes, we do.
Okay, thank you very much. Well, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. This is the last presentation for today. But like Ms. Sardo said, that it might be not least. And I'm Fajar. It is J in Indonesia, not J in Spanish. Yes, we know that in Spanish we call it J like H, like in Mojito, right? So this is very interesting moment. I'm very honored to be here to attend the BICMHS, and I'm here to present my study about the relationship between dietary approach to stop hypertension, or as we know as DASH knowledge, and also the hypertension. This is a collaborative study between the medical faculty of UNISBA, Universitas Islam Bandung, and also with the Ministry of Health, or like in Puskesmas. The previous presenter says that it is called the PHC, or the Public Health Center in English. Okay, the background of this study was our concern about the leading causes of death around the globe. As we can see here in this figure, we can see that the cardiovascular disease is the top leading cause of death around the globe. and they are outnumbered the non-communicable diseases. So this is a great concern for us, especially for us who are in the health field. And one of risk factors for cardiovascular diseases is hypertension, along with hyperlipidemia, diabetes, smoking, obesity, or etc. It may lead to endothelial dysfunction and also atherothrombotic. And then the diseases come up, such as myocardial ischemia, peripheral arterial disease, and also stroke. So the cardiovascular disease here is a response for the main risk factors, for the root of the problem. The root of the problem here, one of them was hypertension. Therefore, we have to manage. We have to cope the hypertension, and we can see here, we can deal with hypertension according to the GNC8 algorithm. And the first line for the intervention is the lifestyle interventions. It is the mainstay. It is the main principle for the therapy of the hypertension. So, what kind of lifestyle that we can apply for the hypertension patient? So, one of the intervention that can be applied is DASH, or it is an acronym for the dietary approach to stop hypertension, that emphasizing consumption of fruits, vegetables, low-fat dairy products, such as whole grains, poultry, fish, and nuts, and also legumes, and accompanied by less consumption of red meat, sweets, sugary drinks, total and saturated fat. Therefore, we have to manage the cholesterol level in the blood. Well, how about in Indonesia? Well, here in Indonesia, 34.11 out of 100 over 18 people of Indonesia were hypertensive. More than a third of the Indonesians are hypertensive. The proportions were larger with the older age respectively. And West Java, as the most dense province in Indonesia, was in second largest hypertension prevalence of Indonesia. 34.9% residents of the West Java capital, Bandung, were hypertensive. This is the location of the study conducted. As we can see here, this is the map of the Bandung city. The colorful map is Bandung city, while the red triangle here is the location of the study conducted. It is the suburban area of the capital, and it was conducted in the public health system, was managed by the district health center, we call it as Puskesmas. And the most prominent disease in the public health center was also the hypertension itself. So how can we manage? How can we manage to be successful in management of the hypertension? We must consider the lifestyle intervention as the first line of the intervention. It is the mainstay of non-pharmacological therapy. However, it is difficult to achieve due to the factors that affected the lifestyle. As we know that the lifestyle is influenced by cultural knowledge, etc. A lot of factors that will influence the lifestyle. Although the DASH and the weight control is known can reduce the blood pressure value by 16.1 per 9.9 millimeter Hg. This is the methods of the study. This is a cross-sectional study collected by primary data. We collected from the examination of blood pressure, and also we interview every samples who met the criteria of purposive sampling, consisted of the inclusion criteria, the exclusion criteria. There are two variables here, from determinant and the outcome variables, from the recognizing DASH or the unfamiliarity with DASH, and outcome were hypertension and no hypertension. So this is the results of this study. Unfortunately, 91% of respondents were not familiar with DASH. And this is the characteristic. Most respondents were female, aged between 36 to 55 years old, and the last education in university. They were working as a civil servant and resided more than 3 years in the area neighboring the public health center. There were only 2.6% of respondents who recognized DASH in hypertension group, lesser than those in non-hypertension group. So it is we can see that the association between recognizing DASH and hypertension is associated. Compared to other references, the DASH intervention is known can reduce the systolic blood pressure in respondents without or with hypertension. The effect of DASH diet was particularly pronounced in individuals with stage 1 hypertension. Where there was a mean reduction in blood pressure up to 11.4 per 5.5 millimeter hydrogen. This intervention also showed a decrease in blood cholesterol and homocysteine levels due to the diet, and could increase the benefits and success of the antihypertensive drug therapy. Therefore, the conclusion, there was a significant relationship between knowledge of DASH and the hypertension. However, there are some limitations of this study. The DASH category groups were incomparable. We can see that only 9% of respondents who knows the DASH. The research was short due to the social limitation during the pandemic. The hypertension group was combined with normal group due to the small samples. And suggestion for this limitation, further research with larger samples and longitudinal study, not cross-sectional study, must be conducted to validate the result of this cross-sectional study. And also, we have to analyze with other variables to minimize the spurious association that we have in the study. But we can see there are advantages for socializing the DASH in the health centers, because we know that 91% of the respondents were not recognizing the DASH. Well, that was all my presentation. Alhamdulillah. Thank you very much for your attention, and I'm open for discussion. Thank you.
Thank you for that presentation, Sir Fahar. Sorry. Okay. So I guess there's none in the chat box, but I think we can allow anybody who would want to ask questions right now. We can just raise our hands. So we can directly. I think that the direction, sir, is very interesting, because you said there is a limitation in the number and who participated, because you said it's a mix combined of the pre-hypertension and the hypertensive. So yeah, that makes it a limitation. However, I'm really looking at a direction on really measuring their blood pressure in a form of experimental later on, or quasi experiment, to see how the DASH program or approach is really affecting their blood pressure. So yeah, that is a good direction, I guess. So there is one question again from Dr. Handro. So it was good also for the population is included the essential hypertension in the family. Let's figure that out. Hold on. Will it be good if the population included will also include essential hypertension? Yeah.
Yeah. Actually, this study is a part of a larger study, and we have additional variables such as the genetic, such as the history of the familial history of the hypertensive, and excluding the other causes of hypertension, such as renal diseases
Yes. Yeah, because we have to control that aspect. If it's is it due to diabetes or renal or any tumor in the adrenal glands that may affect blood pressure. So yeah, we need to. So very interesting. Again, another direction for future studies.
Yeah, because this is a small study that was a part of the larger study. In the study, I have managed to control other variables in multivariable analysis. Therefore, you can read it when it is published.
Right. Okay, I guess we have 3 more minutes. So if there are more questions, it's now high time for us to throw it. And because this is a good line of, I would say, like really direct applied also, when we look at the variations of blood pressure that is really affected by this approach. But I think there's no more. But we can just raise our hands.
May I
yes,
question?
Go ahead,
Dr. Ramirez, I have one question.
Yes, please, ma'am.
This diet is also guide for losing weight, yeah. But I didn't see from your research the weight of the respondent.
Can you repeat it, Prof? I'm sorry.
The diet, the DASH diet also guide to lose weight.
Oh yeah.
Yes. Yeah. Have you? Can you explain about that, or maybe next research you will do that?
Because in the discussion mentioned about how the DASH diet can manage the also the weight, the body weight. So if the body weight combined with the DASH, it is a great combination that can reduce the blood pressure. Therefore, we cannot rely only on the DASH diet itself, but also from the weight controlling measurements.
Okay, thank you.
Yeah, thank you, Prof.
Yes, I agree with that too. There are so many parameters that determines blood pressure. Okay, I guess it is now a wrap up for this public health track for this conference. And so congratulations, paper presenters, for the last group. So thank you. And I think thank you also to Prof. Dr. Liba. It's my honor, ma'am, to be with you today as your co-presenter, co-chair. And so I think it's now time for us to present their certificates. I'm giving back the floor to our tech team.
Yeah.
Thank you.
Okay. Now we come to the last session. Thank you to all presenters. Thank you all audience for participation. Hopefully the information that we shared would be useful for all of us. Finally, give the applause for the speaker and for you all. Thank you, and back to the MC, Dr. Santi. We have finished our job. Thank you, Dr. Cheryl.
Thank you, Doc.
Okay, so over to Mr. Yusuf.
Oh, okay.
Okay.
Well, thank you for the session chair, Professor Dr. Ifa B. Akbar and Dr. Cheryl Ramirez. And now it is the time for both of you to congratulate once again and giving the e-certificate to all the presenters that already shown their best effort in presenting their papers. Please, please, Professor Ifa, also Dr.
Okay, I give the certificate to the first speaker, Mr. Cherry. Thank you for your presentation. It's very useful and very interesting and very informative for us. Congratulations.
Once again, please give a warm of applause.
And next, I will give the appreciation to the second presenter. The second presenter is Fatmawati. Yeah. Okay, Rahma Rizkia. Okay, thank you, Dr. Rasma Rizkia, for your presentation. Very useful and very interesting. And then Miss Eka Nurhayati is our junior, very active lecturer. Thank you for your presentation. It's first for your research, and you can do the next session. Thank you. And the other, I think, will be delivered by Dr. Sheryl Ramirez, please.
Yes, ma'am. Thank you for. So the next certificate is given to for having completed and presented his paper to Noripansha via through Ma'am Lily. Okay, so Ma'am Lily Nabila Amar, sorry about that. And then the next certificate is awarded to Dr. Aldo Dimitri Daiba for presenting his paper, Relationship of Access to Clean Water with Prevalence of Stunting in Puskesmas Cicalengka in 2020. And then the last certificate is awarded to Fahar Awalia Yulianto for his paper, Relationship between Dietary Approach to Stop Hypertension, Knowledge and Hypertension. And that's all. Congratulations to all the paper presenters.
Okay, once again, thank you so much, Professor Dr. Iva Akbar and also Dr. Sheryl Ramirez for the great sharing. But before that, to memorize and also cherish our moment together. So once again, let us have an e-group photos together. So please kindly turn on your Zoom video or camera in your device. Okay, so perhaps this is the last e-group photos, yeah, the last e-group photo before we going to the closing ceremony. Okay, let's see. Hold on. Okay, on my count, everybody look at to your camera. 1, 2, 3, smile. Thank you. And then we continue to the second room. 1, 2, 3, smile. Thank you. And then the last room. Oh, sorry, one more room. One more room. Okay. Okay. Thank you so much for all the wonderful smile. So we almost at the end of our first day of the BICMHS 2021. But before that, once again, allow me to read some important information regarding the post-conference or the publication for the BICMHS 2021. So once again, please pay attention to the timeline and also the process that the author must do in order to complete the post-conference process and get the international journal recommendations, because you need to upload your extended, you need to upload your extended full paper, which is already paraphrased or revised at least 80% of your submitted conference paper to avoid the self-plagiarism. And please submit it not later than 14 days after the conference is finished, or at least at 10 October, 10 October. And then also please bear in mind that the output is already available in the link of the paper proceeding of the BICMHS under the Research Synergy Press website. And then if you have some queries regarding your published conference paper proceeding, do not hesitate to contact the committee to the info@bicmhs.com. So don't forget, after the conference finish, the ISSN, the DOI also will be assigned soon. So your article will be automatically indexed in the Google Scholars, and then later on it will be submitted to the OAG for indexations. Okay, and don't forget again to submit your revisions or your extended, your extended full paper to avoid the self-plagiarism. You can upload it in your Scholar Vein account or email at info@bicmhs.com. And then to close this online presentation sessions, in this opportunity, I would like to invite the two representatives in this room and also in this session to share their experience in participating at the conference. So in order also to encourage other scholars to join the scientific forum. So the first opportunity, I would like to pass this opportunity to our colleague from the Philippines, to Dr. or to Mr. Fer Cedric de Vera, to sharing the experience of the two-day BICMHS 2021. Please welcome Dr. Fer Cedric de Vera to sharing your experience. Okay, you are the lucky representative. Okay, you can unmute. Okay, sorry, you can unmute yourself. Okay. Still mute, still mute. You need to unmute first. Okay.
Hello.
Yeah.
Thank you very much for this opportunity. I really enjoyed it and I learned a lot from this event, from this conference.
Okay, so thank you so much for joining our conference for the BICMHS 2021, and also please pass our regards to your colleagues in the Philippines, in your university, and we are also keen to have a future collaboration with your institutions. Thank you so much. Okay, so and then another representative of these sessions, I would like to give this opportunity to our professor, our doctor, Dr. Hendra Sujono. Doc, would you please to say something, Doc, because you have been actively involved in giving the feedback and also the questions to all the presenter, and we do really highly appreciate on your participations. Please, Prof.
Oh, yes. Thank you very much for the time. Yes, I always like to read and follow all of the presentation. Yeah, because I think all of the presentation today is very good. Yeah, I think I like very much of the thinking, yeah, the result of the paper. Yeah. And yeah, I think it is good then to follow later on with another paper in the other conference or meeting, especially international meeting. Yeah, that's all. And I think very good. The host is very good, and also this international conference meeting is also very nice to attend. Thank you very much.
Thank you very much, Prof, for your active participations in the BICMHS 2021. Thank you so much. Okay, so moving on to the next is, I would like also to remind for all of you, do not forget to fill the feedback forms, and later on also the committee will send the link of the feedback forms in the Zoom chat box. So please kindly fill the feedback form. Okay, pass to Mr. Yusuf.
Okay, thank you, Ms. Santi. And before we go to the closing ceremony of today international conference, I have several information. Since the first plenary session, we have selected the best question as an appreciation to the participant. Likewise, we also have chosen the best question in the second plenary session for the participant who asked. And so please, Dr. Mia, to call the winner of the best question.
Okay, thank you, Mr. Yusuf, for your for me to take the time to present or to announce the winner for the best question in the second plenary session. Yeah, Prof. Kasule. A bit difficult to decide who are the winner. Who are, yeah. Who is, maybe, yeah, who is. I think the best question for the second plenary session is about Islamic bioethic, source of conflict and balance. Will be sent to Dr. Dadang Rukanta, maybe. Dr. Dadang Rukanta, are you still here? Dr.
Yes.
Dadang Rukanta?
Yes. Yes, he is still here.
Okay. Okay, congratulations to your best question for the second plenary session. Yeah, thank you, Mr. Yusuf. I think it's enough.
Okay. Yeah, thank you, Dr. Mia, and then congratulations for the winner. And also we have another information. Please remember that at 4:20 p.m. we will have closing ceremony. At the closing ceremony, there will be announcement for the best presentation category and acknowledgement for session chairs. So please ensure that all the participants stay until the end of today's conference session. Now we will have short break until 4:20 p.m. Once again, thank you so much for your kind attention and see you soon again at 4:20 p.m. Thank you very much.
Thank you. And don't forget, we still have the closing ceremony.
Yeah.
Thank you.
Ya, 4:20.
Largest metropolitan city in West Java province, which is also known as an education city, which has a scientific treasure and has many universities. One of these is Universitas Islam Bandung, which has established since 1958, based on the ideas of several Muslim figures. As a higher education, which has an Islamic academic cultures as its educational strategy, philosophically, Universitas Islam Bandung offers a comprehensive education principles. Since its establishment, UNISBA has launched 10 faculties of bachelor degrees, or S1, as follows: Sharia, Dakwah, Tarbiyah and Teacher, Law, Psychology, Mathematics and Natural Sciences, Engineering, Economic programs as 3. Support from rector, lecturers, staff, and student creativities who keep innovating in developing superior educational facilities. To support academic activities, UNISBA is stated as a major university, thus obtain an A accreditation from National Accreditation for Higher Education. Year to year, UNISBA is increasingly showing its independence to become a leading university that proven from several national and international awards. achieved the international accreditation for 14 study programs, with the highest premier assessment, which conducted by the Accreditation Service for International Schools, College, and Universities based in the UK.
Sebagai perguruan tinggi swasta berdasarkan Islam, Universitas Islam Bandung atau UNISBA memiliki nilai lebih dibanding perguruan tinggi swasta lainnya karena selalu memasukkan nilai keislaman dalam setiap aspek pengajaran, penelitian maupun pengabdian kepada masyarakat. UNISBA menjadi sebuah perguruan tinggi Islam yang memberikan kontribusi dan solusi dalam menuntaskan berbagai permasalahan yang dihadapi masyarakat. Akan mendorong terwujudnya visi menjadi perguruan tinggi yang mandiri, maju dan terkemuka di Asia.
By trying to generate students as a student with 3M characters, Mujahid, Mujtahid, and Mujadid characters, together the superior generation with Akhlaqul Karimah, UNISBA requires its students to take a part in the Islamic boarding program for new students, Islamic boarding program for graduate prospective, with the Islamic boarding program of prospective doctors. This is the expected breakthrough to answer the time challenges, competitive and competitive challenges. This is also proven from national and international achievements that achieved by students.
Okay. Alhamdulillah, all the recapitulations for the determining the best presentations is already finished. Okay, so we will continue. So once again, welcome back. So we will make it in advance, yeah, for the closing ceremony since it is already prepared. So welcome back the participants and also the distinguished guests. So once again, thank you so much for all the excitement of the first day in the BICMHS. As we have already informed at the opening ceremony this morning, so by the end of today's conference, we will announce the best presentation awards and also the recognitions for the session chairs. Mr. Yusuf?
Well, the session chairs had selected the best presentation based on several criteria in the assessment form. Well, thank you to all presenters that gave his or her best efforts in delivering the research through the presentation. There is one best presentation for today's conference. On this occasion, we would like to give a special token of appreciation and recognition to the best presentation. Kindly please welcome Dr. Santun Bekti Rohimah Dr. MKes as the first Deputy Dean of UNISBA Medical Faculty to give away an certificate as a token of appreciation and recognition to the best presentation.
Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good afternoon, ladies and gentlemen, the speaker and all participants at the first day of Bandung International Conference on Medical and Health Science 2020. During this day, the committee have conducted online presentation from 9 presenters with the scope topic about infection, anatomy, pathology, public health, and etc. Each presenter have been marking by the judge at each station, and the highest mark will become the best oral presentation for this day. The presenter was evaluated according to the this criteria that is significant of the paper at the field, theoretical contribution, the ability of practical implementation, use of the appropriate methodological rigor, originality, and total mark gain in the presentation. Okay, The next thing I would like to say, we are happy to announce the best online oral presentation in Bandung International Conference on Medical and Health Science, BICMHS 2020. For this day, the best oral presentation for today is to be given to, the slide please, Fajar Awalia Yulianto. I'm sorry I can mention the title of the article because it is too small few for me about the relationship between dietary approach to stop hypertension, knowledge, and hypertension. Congratulations for Dr. Fajar. It is my colleague from Medical Faculty of UNISBA. I'm very proud of him. And the winner will receive a certificate of appreciation and some prize from the committee. That's maybe the announcement for the best oral presentation for this for the first day, and hopefully all the participants will be able to be participate in maybe inshallah second BICMHS 2022. Thank you.
Thank you very much, Dr. Santun Bekti Rahima. And also congratulations to Dr. Fajar Awalia Yulianto for the winner of this best presentation. Then
Okay.
back to Ms. Santi.
Thank you. So moving on to our second award category is for the session chair. On behalf of the organizing committee, we would like to appreciate and thank all session chairs today, because with his and her contribution during the presentation session, the scientific forum, feedback discussion, and knowledge sharing environment has been built to encourage participation from all the participants. So kindly, please welcome again Dr. Santun Bekti Rahima, Dr. MKes, as the first Deputy Dean of the UNISBA Medical Faculty, to give away the certificate and also the token of appreciations to the session chair. Please welcome Dr. Santun.
Thank you, Ms. Santi. I say thank you for Professor Nur Halim, Professor Iva, and also Ms. Cheryl Ramirez from Philippines for your time and willingness to become a moderator at the chair session in BICMHS 2020. And thank you for leading the session with smoothly, interesting, and also interactive. Once again, thank you for all. I really appreciate your contribution. Thank you. This is for Dr. Ramirez and Prof. Halim and Prof. Iva.
Thank you so much, Dr. Santun, for giving and also congratulate to all, and also to give the special recognitions to our session chairs in the first day of the Bandung International Conference on Medical and Health Sciences.
And once again, we would like to invite Dr. Santun Bekti Rahima as the first Deputy Dean of UNISBA Medical Faculty to deliver the closing speech of the first day of BICMHS 2021. And before that, I would like to read her profile. Dr. Santun Bekti Rahimah, Dr. MKes, born in Bandung on June 23rd. She completed her undergraduate to postgraduate education at the Faculty of Medicine, Universitas Padjadjaran Bandung, Indonesia. Her specialty is pharmacology. She has held various positions before joining the UNISBA Medical Faculty, including being the head of the Cimareme Health Center and being the Deputy Director 2 of the Akbar Bidaya Mukti. She is currently served as Deputy Dean 1 of UNISBA Medical Faculty. Besides being active in the three Dharma activities of higher education, she is also very active in organizations, including being a Master of Trainer for the West Java Province Women's Empowerment Program Sekoper Cinta, Secretary of AIPKI Region 3, and Treasurer of the IKAVI Management. Please welcome Dr. Santun Bekti Rahimah, Dr. MKes. The floor is yours.
Thank you. Thank you, sir. I think it is very honor for me to have opportunity to become close ceremony at the end of the first day. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Innal hamdalillah nahmaduhu wa nasta'inu wa na'udzubillahi min syururi anfusina wa min sayyiati amalina. Man yahdihillahu fala mudhillalah wa man yudhlilhu fala hadiyalah. Asyhadu an la ilaha illallah wa asyhadu anna Muhammadan abduhu wa rasuluh. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. I believe that during this day, from the morning until this time, all of us has obtained a fruitful discussion in the Bandung International Conference on Medical and Health Science, BICMHS 2020, whose main theme is strengthening medical research from basic to clinic toward international recognition. We have learned a lot from the keynote session delivered by the amazing keynote speaker, Professor Nanan, is our Dean in Medical Faculty of FKUnisba, and another invited speaker who have shared their interesting work. Once again, on behalf of the committee, thank you for Professor Haris, Ms. Aliza, and also Professor Omar Kasule for delivering such important material so that all of us can deepen our knowledge about the topic. Furthermore, I would like to thank all presenter, moderator, and all participants who have joined this conference from all over the world. I'm certain that every presenter has presented the field of interest at the research. I sincerely hope that through your presentation and discussion afterward can improve your research further, and maybe all of us can contribute to solving the medical problem correlated to the research field, even though the contribution is maybe small, but is still valuable. This is the first day of the conference, and tomorrow we will continue the event. Tomorrow there will be very interesting speaker with update topic and also oral presentation from other participants regarding their research. Finally, I would like to thank all the committee members for organizing this conference and ensuring that it proceeds smoothly. I would also like to apologize for any inconvenience that you might be experienced during this conference. Hopefully, the shortcoming that exists today can be fixed for the further. Thank you once again for your participating, and wish you all can still join the conference until the end tomorrow. Have a nice day, stay safe and healthy during this pandemic. Please send our best regard for all your family members. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Tantun Bekti Rahima, for the speech. And back to Ms. Santi.
Thank you. So finally, we are at the end of Bandung International Conference on Medical and Health Science, BICMHS Day 1. So ladies and gentlemen, distinguished participants and attendees, we hope it has been a beneficial and fruitful day for all of you. On behalf of the host and the organizing committee, the Medical Faculty of Universitas Islam Bandung, the Research Synergy Foundation, and UPT Publikasi Ilmiah Unisba, and also supported by Scholar Fame, Research Synergy Institute, Viewer Track, RSF Press, F1000 Research, and Teller and Francis Group, in conjunction with the 17th anniversary or Milad of the Medical Faculty of Universitas Islam Bandung. Thank you once again to all the distinguished participants for taking the time to join us in the Bandung International Conference on Medical and Health Sciences Day 1. So we still have Day 2. Yeah,
it has been our pleasure to host this online event. See you again tomorrow in the BICMHS 2021 Day 2. Please take a good rest stay healthy and safe. Thank you very much, and wassalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah. Hatur nuhun Ibu, Bapak semuanya.
Semuanya sama-sama.
Pak Yusuf,
Prof, Bapak, Ibu semuanya. Izin lab.
Mangga. Feel free to leave the room.
Recording stopped.